Welcome to this comprehensive continuing education course on lumbar spinal stenosis. This evidence-based update is designed for physical therapists, occupational therapists, nurses, and allied health professionals who encounter this increasingly common condition in clinical practice. Lumbar spinal stenosis has emerged as one of the defining musculoskeletal conditions of our aging population. With approximately 103 million individuals affected worldwide and prevalence continuing to rise as demographics shift toward older age distributions, rehabilitation professionals across all practice settings encounter this condition with increasing frequency. As the leading indication for spinal surgery in adults over 65 years of age, with more than 450,000 lumbar decompression procedures performed annually in the United States alone, lumbar spinal stenosis represents both a significant clinical challenge and a substantial opportunity for rehabilitation professionals to impact patient outcomes through evidence-based conservative management. This continuing education course provides a comprehensive, evidence-based update on the assessment and rehabilitation management of lumbar spinal stenosis for physical therapists, occupational therapists, nurses, and allied health professionals. The content synthesizes the most current research literature, including systematic reviews, randomized controlled trials, and clinical practice guidelines published between 2022 and 2025, ensuring that participants receive information that reflects the contemporary state of the science. The 45 peer-reviewed references supporting this course represent the highest quality evidence available, with emphasis on systematic reviews and meta-analyses that provide the strongest foundation for clinical decision-making. Upon completion of this course, you will be able to accomplish 7 specific learning objectives. First, you will be able to differentiate between central canal stenosis, lateral recess stenosis, and foraminal stenosis based on anatomical location, pathoanatomical features, and characteristic clinical presentations. Second, you will be able to contrast lumbar spinal stenosis from key differential diagnoses, including peripheral artery disease, hip osteoarthritis, lumbar disc herniation, and diabetic peripheral neuropathy, using specific clinical features, physical examination findings, and diagnostic tests. Third, you will be able to apply validated clinical assessment criteria, including the N-class scoring system and provocative maneuvers, to evaluate patients presenting with suspected neurogenic claudication. Fourth, you will be able to select appropriate evidence-based rehabilitation interventions, including manual therapy, flexion-based exercises, trunk stabilization, and aerobic conditioning based on patient presentation, symptom severity, and functional status. Fifth, you will be able to compare short-term and long-term outcomes of supervised multimodal rehabilitation versus surgical decompression, including rates of clinically meaningful improvement, complication profiles, and outcome convergence over time. Sixth, you will be able to evaluate clinical and demographic predictors of favorable response to rehabilitation versus surgery to guide individualized treatment recommendations and shared decision-making. And seventh, you will be able to determine appropriate exercise modifications and monitoring protocols for older adults with lumbar spinal stenosis who present with high comorbidity burden, frailty, or multiple concurrent conditions. Let us now begin Module 1, which covers the pathophysiology, epidemiology, and classification of lumbar spinal stenosis. Lumbar spinal stenosis represents one of the most common and clinically significant degenerative conditions affecting the aging spine. As populations worldwide continue to age, rehabilitation professionals encounter this condition with increasing frequency across all practice settings. Understanding the fundamental pathophysiology, epidemiological patterns, and classification systems for lumbar spinal stenosis provides the essential foundation for effective clinical assessment and evidence-based intervention planning. This module establishes the scientific basis upon which subsequent modules on clinical assessment, rehabilitation protocols, and outcome prediction are built. The clinical syndrome of lumbar spinal stenosis encompasses far more than simple radiographic narrowing of the spinal canal. It represents a complex interplay between structural changes in the vertebral column and the resulting neurological compromise that produces the characteristic symptom pattern of neurogenic claudication. Rehabilitation professionals must understand both the anatomical substrates of this condition and its clinical manifestations to provide optimal patient care and engage effectively in shared decision-making regarding treatment options. Let us begin by defining lumbar spinal stenosis and distinguishing between the clinical syndrome and the radiographic finding. Lumbar spinal stenosis is defined as a clinical syndrome characterized by buttock or lower extremity pain, with or without low back pain, that is associated with diminished space available for the neural and vascular elements in the lumbar spine. This definition, established through expert consensus and validated through decades of clinical research, emphasizes a critical distinction that has profound implications for clinical practice. Lumbar spinal stenosis is fundamentally a clinical syndrome rather than merely a radiographic diagnosis. The narrowing of the spinal canal, lateral recesses, or neural foramina observed on imaging studies constitutes the structural basis for the condition, but the diagnosis requires correlation between these anatomical changes and characteristic clinical symptoms. This distinction between clinical syndrome and radiographic finding carries substantial practical importance. Population-based imaging studies consistently demonstrate that a significant proportion of asymptomatic older adults have radiographic evidence of spinal canal narrowing that meets structural criteria for stenosis. Conversely, some patients with classic neurogenic claudication symptoms may demonstrate only modest degrees of canal narrowing on imaging. The comprehensive 2022 review by Katz and colleagues in the Journal of the American Medical Association reinforces that the diagnosis of clinically meaningful lumbar spinal stenosis requires integration of patient history, physical examination findings, and imaging results rather than reliance on any single element in isolation. The hallmark clinical feature of lumbar spinal stenosis is neurogenic claudication, a symptom complex characterized by pain, paresthesias, or weakness in the buttocks and lower extremities that is provoked by walking or prolonged standing and relieved by sitting or forward flexion of the lumbar spine. This postural dependency of symptoms reflects the dynamic nature of neural compression in the stenotic spine. Lumbar extension decreases the cross-sectional area of the spinal canal and neural foramina, while flexion increases available space and reduces compression of neural elements. Patients often describe the characteristic shopping cart sign, wherein they experience symptom relief when leaning forward on a shopping cart during ambulation, as this posture induces relative lumbar flexion. Now let us examine the epidemiological burden and clinical significance of this condition. The epidemiological burden of lumbar spinal stenosis is substantial and growing. Current estimates indicate that approximately 103 million individuals worldwide are affected by this condition, with prevalence rates of approximately 11% among adults in the United States. These figures establish lumbar spinal stenosis as one of the most common degenerative spinal conditions encountered in clinical practice. The condition demonstrates a strong age-related pattern, with prevalence increasing dramatically after the fifth decade of life and reaching peak incidence in individuals aged 65 to 74 years. The clinical and healthcare system impact of lumbar spinal stenosis extends well beyond its prevalence figures. This condition currently represents the leading indication for spinal surgery in patients over 65 years of age, with more than 450,000 lumbar decompression procedures performed annually in the United States alone. The associated healthcare expenditures, including surgical interventions, rehabilitation services, pain management, and disability-related costs, place lumbar spinal stenosis among the most economically significant musculoskeletal conditions. For rehabilitation professionals, these statistics underscore the critical importance of developing expertise in evidence-based conservative management strategies that may reduce surgical utilization while optimizing functional outcomes. Age-related patterns in lumbar spinal stenosis reflect the degenerative etiology of this condition in the vast majority of cases. While the structural changes that produce stenosis may begin developing in middle age, symptomatic presentation typically occurs in the 6th through 8th decades of life. Recent research examining age diversity in surgical populations has demonstrated that patients aged 75 years and older present with significantly higher rates of frailty, polypharmacy, and comorbidity burden compared to younger patients with the same diagnosis. These findings have important implications for rehabilitation planning, as elderly patients may require modified treatment approaches, enhanced monitoring, and adjusted outcome expectations. Sex-based differences in lumbar spinal stenosis prevalence and presentation have been observed in epidemiological studies, though the patterns are not entirely consistent across populations. Some studies suggest modestly higher prevalence in males, while others demonstrate relatively equal distribution between sexes. What appears more consistent is that female sex has been identified as a risk factor for residual symptoms following surgical intervention, suggesting potential differences in treatment response that may inform rehabilitation planning and prognostic counseling. Let us now turn to the pathophysiological mechanisms underlying this condition. The pathophysiology of degenerative lumbar spinal stenosis involves a cascade of age-related changes affecting multiple anatomical structures that collectively contribute to narrowing of the spaces available for neural elements. Understanding these mechanisms provides the foundation for appreciating both the structural basis of symptoms and the rationale for various treatment approaches, including the flexion-based exercise strategies that form a cornerstone of rehabilitation management. Intervertebral disc degeneration typically initiates the pathophysiological cascade leading to spinal stenosis. As disc hydration decreases with age, the nucleus pulposus loses height and the annulus fibrosus develops fissures and bulging. This loss of disc height has multiple downstream effects. It increases loading on the posterior elements of the spine, particularly the facet joints. It allows the ligamentum flavum to buckle inward toward the spinal canal, and it narrows the neural foramina through which the spinal nerve roots exit. The relationship between disc degeneration and stenosis development explains why lumbar spinal stenosis most commonly affects the L4-L5 and L3-L4 levels, which experience the greatest mechanical loading and demonstrate the highest rates of degenerative disc disease. Facet joint hypertrophy represents a major contributor to both central canal and lateral recess stenosis. As disc height is lost and mechanical loading shifts posteriorly, the facet joints undergo osteoarthritic changes including cartilage degeneration, subchondral sclerosis, and osteophyte formation. The hypertrophied facet joints, particularly their anteromedial aspects, encroach upon the lateral recesses and central canal. Recent research has identified specific radiographic parameters associated with facet joint osteoarthritis severity in stenosis patients, including facet joint tropism, pelvic incidence, and intervertebral height index, demonstrating the complex biomechanical relationships underlying stenosis development. The ligamentum flavum, which forms the posterior boundary of the spinal canal, undergoes both hypertrophy and buckling as part of the degenerative cascade. Histological studies have demonstrated that the ligamentum flavum in stenosis patients shows increased collagen deposition, decreased elastin content, and fibrosis compared to age-matched controls. These changes result in thickening of the ligament, which is further exacerbated by the buckling that occurs secondary to loss of disc height. The contribution of ligamentum flavum changes to stenosis is particularly significant because this structure directly borders the dural sac and nerve roots, making even modest thickening clinically relevant. The narrowing of the spinal canal and neural foramina produces symptoms through two primary mechanisms: mechanical compression of neural elements and compromise of the vascular supply to nerve roots. Direct mechanical compression of the cauda equina and individual nerve roots causes the radicular symptoms characteristic of the condition. However, vascular factors play an equally important role, particularly in explaining the exercise-induced nature of neurogenic claudication. During walking, metabolic demands of the nerve roots increase, requiring enhanced blood flow. In the stenotic spine, vascular structures are compressed along with neural elements, and the venous congestion that develops during upright posture further compromises perfusion. This ischemic component explains why symptoms develop progressively during ambulation and resolve with rest, a pattern that parallels vascular claudication but with the critical distinction of postural rather than purely circulatory dependence. Recent research has examined the role of paraspinal muscle changes in lumbar spinal stenosis outcomes. A longitudinal cohort study by Wesselink and colleagues found that lumbar intramuscular fat content of 50% or greater was associated with significantly worse 5-year recovery following surgical decompression, with odds ratios ranging from 2.26 to 7.32, depending on the outcome measure. Notably, erector spine and intramuscular fat content did not demonstrate the same prognostic significance. These findings suggest that paraspinal muscle quality may influence both stenosis progression and treatment outcomes, providing a potential target for rehabilitation interventions. Now let us discuss the anatomical classification of lumbar spinal stenosis. Anatomical classification of lumbar spinal stenosis based on the location of narrowing provides essential information for understanding symptom patterns, planning interventions, and communicating with surgical colleagues. 3 primary types are recognized: central canal stenosis, lateral recess stenosis, and foraminal stenosis. Many patients demonstrate stenosis at multiple sites, and the clinical presentation reflects the combined effects of all areas of narrowing. Central canal stenosis involves narrowing of the central spinal canal, which houses the cauda equina at lumbar levels. The boundaries of the central canal include the posterior aspect of the vertebral body and intervertebral disc anteriorly, the pedicles laterally, and the ligamentum flavum and laminae posteriorly. Central canal stenosis typically produces bilateral lower extremity symptoms, as compression affects the cauda equina rather than individual nerve roots. Patients classically describe the gradual onset of bilateral buttock, thigh, and leg symptoms during ambulation, with symptom distribution often described as stocking pattern or affecting multiple dermatomal distributions simultaneously. Severity grading for central stenosis is commonly based on the percentage reduction in canal cross-sectional area or the degree of dural sac compression. Mild stenosis involves reduction of less than 1/3, moderate stenosis involves reduction of 1/3 to 2/3, and severe stenosis involves reduction of greater than 2/3 of normal canal dimensions. The lateral recess, also termed the subarticular zone or Lee's entrance zone, represents the area between the central canal and the neural foramen through which the traversing nerve root passes. This region is bounded by the posterior vertebral body anteriorly, the pedicle laterally, and the superior articular process of the facet joint posterolaterally. Lateral recess stenosis produces radicular symptoms corresponding to the affected nerve root level. Because the L5 nerve root traverses the L4-L5 lateral recess before exiting through the L5-S1 foramen, lateral recess stenosis at L4-L5 produces L5 radicular symptoms. This distinction from foraminal stenosis, which affects the exiting nerve root, is clinically important and should be understood by rehabilitation professionals communicating with surgical teams. Patients with lateral recess stenosis typically present with more unilateral, dermatomally distributed symptoms compared to the bilateral, multi-level pattern of central canal stenosis. Foraminal stenosis involves narrowing of the neural foramen, the opening through which the spinal nerve root exits the spinal canal. The foramen is bounded by the pedicles superiorly and inferiorly, the vertebral body and intervertebral disc anteriorly, and the facet joint posteriorly. Loss of disc height is a primary contributor to foraminal stenosis, as the superior-inferior dimension of the foramen is directly related to disc height. Foraminal stenosis affects the exiting nerve root at that level, thus L4-L5 foraminal stenosis compresses the L4 nerve root. Patients with foraminal stenosis often describe radicular pain that may be exacerbated by lumbar extension and ipsilateral lateral flexion, which further narrow the foramen. Foraminal stenosis may occur in isolation or in combination with central and lateral recess stenosis. Advanced imaging techniques, including MRI and CT, can reliably identify and grade foraminal narrowing, though correlation with clinical symptoms remains essential for determining clinical significance. Contemporary artificial intelligence approaches have been developed to assist in the classification and grading of lumbar spinal stenosis on MRI. A systematic review by Verheijen and colleagues examined machine learning models for segmentation and classification of stenosis, finding that deep learning methods, particularly UNet-based architectures, achieved excellent performance comparable to radiologist subspecialists. Similarly, neural network models have demonstrated high sensitivity and specificity for detecting and classifying central, lateral recess, and foraminal stenosis. While these technologies remain primarily research tools, they illustrate the ongoing evolution of diagnostic approaches and may eventually enhance clinical workflow efficiency. Beyond anatomical location, lumbar spinal stenosis can be classified according to etiology. The distinction between congenital or developmental stenosis and acquired or degenerative stenosis has implications for patient age at presentation, symptom progression, and treatment planning. Congenital stenosis results from developmental abnormalities that produce a constitutionally narrow spinal canal. Patients with congenital stenosis have shortened pedicles, reduced interpedicular distance, and decreased anteroposterior canal diameter from birth. While these individuals may remain asymptomatic during youth, they have reduced reserve capacity and become symptomatic with lesser degrees of superimposed degenerative change than would be required to produce symptoms in patients with normal canal dimensions. Congenital stenosis should be suspected in patients who develop symptomatic stenosis at relatively young ages, particularly before the 5th decade of life. Achondroplasia represents the most severe form of congenital stenosis, with affected individuals often developing symptomatic stenosis in early adulthood. Acquired degenerative stenosis accounts for the overwhelming majority of clinical presentations and results from the age-related changes described in the Pathophysiology section. Within the category of acquired stenosis, degenerative spondylolisthesis deserves specific mention as a common contributing factor. Spondylolisthesis, the anterior translation of one vertebra relative to the adjacent inferior vertebra, occurs most commonly at L4-L5 and produces dynamic central canal stenosis that worsens with lumbar extension. The management of stenosis with concurrent spondylolisthesis has been an area of significant research, with recent high-quality evidence demonstrating that decompression alone provides equivalent outcomes to decompression plus fusion for most patients with degenerative spondylolisthesis. This finding has important implications for surgical decision-making and postoperative rehabilitation planning. Less common causes of acquired stenosis include metabolic bone diseases such as Paget's disease, which produces bony overgrowth that may encroach upon the spinal canal, epidural lipomatosis, an accumulation of epidural fat often associated with obesity or corticosteroid use, post-surgical changes including epidural fibrosis and adjacent segment degeneration, and space-occupying lesions including synovial cysts arising from facet joints. Rehabilitation professionals should be aware of these less common etiologies, as they may influence treatment response and prognosis. Understanding the natural history of lumbar spinal stenosis is essential for counseling patients, establishing realistic expectations, and making informed treatment decisions. Contrary to the perception that spinal stenosis inevitably progresses, longitudinal studies have demonstrated a variable clinical course. Approximately one-third of patients experience spontaneous improvement in symptoms over time, approximately half remain stable without significant change, and 10 to 20% experience symptom worsening over a 3 to 5 year period. These figures apply to patients managed conservatively and underscore that surgical intervention is not inevitably required. The factors that determine which patients will improve, remain stable, or worsen remain incompletely understood, though several predictors have been identified. Patients with mild to moderate symptoms, shorter symptom duration, and preserved walking capacity appear more likely to respond favorably to conservative management. Conversely, patients with severe symptoms, progressive neurological deficits, and marked functional limitation are more likely to require surgical intervention. Specific predictors of conservative treatment failure have been identified in recent research, including caudal foraminal stenosis location and positive straight leg raise testing. These findings can help guide clinical decision-making regarding the intensity and duration of conservative treatment trials. The relationship between radiographic severity and clinical trajectory adds complexity to prognostic counseling. Some patients with severe radiographic stenosis maintain stable symptoms for years, while others with seemingly modest structural changes experience progressive functional decline. This discordance between imaging findings and clinical course reinforces the importance of clinical assessment rather than imaging alone in determining treatment approaches. Recent research by Shahidi and colleagues has demonstrated that stenosis severity on imaging does not predict responsiveness to exercise-based rehabilitation, with patients across all severity grades demonstrating similar patterns of improvement with appropriate intervention. This finding has important implications for rehabilitation practice, suggesting that even patients with severe stenosis should be offered comprehensive conservative treatment. The pathophysiological and classification concepts presented in this module have direct implications for rehabilitation assessment and intervention planning. Understanding that lumbar extension decreases canal dimensions while flexion increases available space provides the rationale for flexion-based exercise approaches that form a cornerstone of evidence-based rehabilitation for this population. Recognizing the anatomical location of stenosis helps predict symptom patterns and may influence the selection of specific manual therapy and exercise techniques. The epidemiological data on age distribution and comorbidity burden inform the approach to special populations. Older patients with lumbar spinal stenosis frequently present with concurrent conditions, including cardiovascular disease, diabetes, and frailty that influence treatment selection and intensity. Recent research has demonstrated that frailty status, while associated with worse baseline function and radiographic parameters, does not preclude meaningful improvement with appropriate intervention, though it may moderate the magnitude of gains achieved. Similarly, polypharmacy, particularly hyperpolypharmacy involving 10 or more medications, has been associated with worse outcomes and should be considered in treatment planning. The variable natural history of lumbar spinal stenosis supports the role of rehabilitation as primary management for the majority of patients. Given that the majority of patients will improve or remain stable without surgery, comprehensive conservative treatment represents the appropriate initial approach for most clinical presentations. The subsequent modules in this course will detail the specific components of evidence-based rehabilitation, the assessment tools used to monitor progress, and the clinical decision-making frameworks that guide treatment selection and progression. We now move to Module 2, which covers clinical assessment and differential diagnosis. Accurate clinical assessment of lumbar spinal stenosis requires systematic integration of patient history, physical examination findings, and diagnostic imaging. Rehabilitation professionals serve as frontline clinicians who must recognize the characteristic presentation of neurogenic claudication, differentiate it from conditions with overlapping symptom profiles, and identify patients requiring urgent medical referral. This module provides a comprehensive framework for clinical evaluation that supports diagnostic accuracy and informs treatment planning across the continuum of conservative and surgical management options. The clinical assessment of lumbar spinal stenosis presents unique challenges. Unlike many musculoskeletal conditions where symptoms correlate predictably with structural findings, patients with stenosis may demonstrate significant discordance between radiographic severity and clinical presentation. Furthermore, the population most commonly affected by this condition, older adults, frequently presents with multiple concurrent conditions that may mimic, mask, or modify the classic stenosis presentation. Developing expertise in systematic clinical reasoning enables rehabilitation professionals to navigate this complexity and provide optimal patient care. Let us begin with a detailed examination of the clinical presentation of neurogenic claudication. Neurogenic claudication represents the hallmark clinical syndrome of lumbar spinal stenosis and provides the primary basis for clinical diagnosis. The term claudication derives from the Latin claudicare, meaning to limp, and describes the characteristic limitation in walking capacity that defines this condition. Unlike vascular claudication, which results from arterial insufficiency, neurogenic claudication arises from compression and ischemia of neural elements within the narrowed spinal canal. Understanding the distinctive features of neurogenic claudication enables reliable differentiation from vascular and other causes of exertional lower extremity symptoms. Patients with neurogenic claudication characteristically describe bilateral lower extremity symptoms that develop progressively during walking or prolonged standing. The symptom complex typically includes aching pain in the buttocks, thighs, and calves. Paresthesia is described as numbness, tingling, or pins and needles, and subjective weakness or heaviness in the legs. Symptoms often begin proximally in the buttocks and progress distally into the legs with continued ambulation, a pattern sometimes described as descending claudication. The bilateral nature of symptoms reflects compression of the cauda equina within the central canal, though asymmetric presentations with predominant unilateral symptoms may occur when lateral recess or foraminal stenosis is the primary pathology. The defining characteristic of neurogenic claudication is its postural dependency. Symptoms are provoked by positions that induce lumbar extension and relieved by positions that promote lumbar flexion. Walking on level ground or standing erect places the lumbar spine in relative extension, decreasing the cross-sectional area of the spinal canal and neural foramina and exacerbating neural compression. Conversely, sitting, bending forward, or assuming a squatting position induces lumbar flexion, which increases canal dimensions and provides symptom relief. This postural relationship explains several classic clinical observations that aid in diagnosis. The shopping cart sign describes the observation that patients with neurogenic claudication experience prolonged walking tolerance when pushing a shopping cart or walker, as leaning forward on these devices induces relative lumbar flexion. Patients often report spontaneously that they can walk much farther in the grocery store than on the street, or that they prefer using a cart, even when purchasing few items. Similarly, patients frequently note that walking uphill is easier than walking downhill or on level ground, as uphill ambulation naturally promotes forward trunk lean and lumbar flexion. Cycling, which is performed in a flexed posture, is typically well tolerated despite significant exertion, contrasting sharply with the limitation in level walking. The relief pattern in neurogenic claudication differs importantly from that in vascular claudication. Patients with neurogenic claudication require position change for symptom resolution. Simply stopping walking while remaining upright provides incomplete or delayed relief. In contrast, patients with vascular claudication experience relief within 1 to 2 minutes of cessation of walking regardless of posture, as their symptoms reflect muscle ischemia that resolves with reduced metabolic demand. Asking patients specifically about the posture required for relief provides valuable diagnostic information. Assessment of walking capacity provides both diagnostic information and a functional outcome measure for monitoring treatment response. Patients should be asked to estimate their comfortable walking distance before symptom onset and their maximum walking distance before symptoms force them to stop. These distances may range from less than 1 block in severe cases to several hundred meters in milder presentations. Walking capacity correlates with quality of life and represents a clinically meaningful outcome that resonates with patients' functional goals. Research on outcome instruments has identified walking capacity as among the most responsive measures to both conservative and surgical intervention, supporting its use in clinical monitoring. The time course of symptom onset provides additional diagnostic information. Neurogenic claudication typically develops gradually over the first several minutes of walking, with symptoms intensifying progressively until the patient must stop or modify their posture. This gradual onset contrasts with radicular pain from disc herniation, which is often present from the first step or provoked by specific movements rather than cumulative activity. Patients should also be asked about symptom behavior during the day, as many individuals with stenosis report greater limitation later in the day after accumulated activity. Physical examination of the patient with suspected lumbar spinal stenosis serves multiple purposes: confirming the presence of findings consistent with the diagnosis, assessing neurological status, identifying examination features that support alternative diagnoses, and establishing baseline measures for monitoring treatment response. The examination should be systematic and include assessment of gait, posture, lumbar range of motion, neurological function, and provocative testing. Importantly, physical examination findings in lumbar spinal stenosis may be subtle or absent, particularly when the patient is examined at rest in the clinic setting after having been seated in the waiting room. Observation of gait provides valuable diagnostic information and should be performed early in the examination. Patients with lumbar spinal stenosis may demonstrate a wide-based gait, reduced stride length, and forward flexed trunk posture. The forward flexion, sometimes called a simian or stooped posture, represents an adaptive strategy that maintains the lumbar spine in relative flexion to maximize canal dimensions. Gait speed is often reduced, and patients may demonstrate hesitancy or need to pause during ambulation. In more advanced cases, balance impairment and increased fall risk may be evident. If possible, observing the patient's gait over a sufficient distance to provoke symptoms provides more diagnostically useful information than brief observation in the examination room. Postural assessment in standing reveals the typical loss of lumbar lordosis seen in many patients with stenosis. This postural adaptation, while protective in terms of symptom management, may contribute to global spinal imbalance and has implications for exercise prescription. Sagittal balance assessment, including observation of the relationship between the head, trunk, and pelvis, provides information relevant to rehabilitation planning and prognostic counseling. The neurological examination assesses sensory function, motor strength, and deep tendon reflexes in the lower extremities. Findings may be subtle and are often more pronounced after provocative testing or exercise. Sensory examination should assess light touch and pinprick sensation in dermatomal distributions, with particular attention to the L4 dermatome covering the medial leg and foot, the L5 dermatome covering the lateral leg and dorsum of foot, and the S1 dermatome covering the lateral foot and sole. These are the dermatomes most commonly affected by lumbar stenosis. Patients may demonstrate decreased sensation in a non-dermatomal stocking distribution when central canal stenosis affects multiple nerve root levels. Motor examination should include assessment of hip flexion, which corresponds to L2, L3, knee extension, which corresponds to L3, L4, ankle dorsiflexion, which corresponds to L4, L5, great toe extension, which corresponds to L5, and ankle plantar flexion, which corresponds to S1, S2. Weakness, when present, is often mild and may be detectable only with careful manual muscle testing using appropriate stabilization and resistance. The extensor hallucis longus, which receives primary innervation from the L5 nerve root, is particularly sensitive to stenosis-related compression and should be carefully assessed. Motor findings that are present at rest indicate more advanced neural compromise and may influence treatment recommendations. Deep tendon reflex assessment includes the patellar reflex, which corresponds to L3, L4, and Achilles reflex, which corresponds to S1, S2. Diminished or absent reflexes may indicate nerve root compression at the corresponding level. However, reflex changes must be interpreted in the context of the patient's age, as diminished Achilles reflexes are common in older adults without stenosis. Asymmetric reflex findings are generally more diagnostically significant than bilaterally diminished reflexes. The Romberg test, which assesses proprioceptive function by having the patient stand with feet together and eyes closed, may be positive in patients with stenosis affecting sensory nerve fibers. Provocative testing attempts to reproduce or exacerbate symptoms through maneuvers that alter spinal canal dimensions. The lumbar extension test, performed by having the patient extend the lumbar spine while standing or prone, is positive when it reproduces lower extremity symptoms. The 30-second extension test, a component of validated clinical prediction rules, involves having the patient maintain lumbar extension for 30 seconds while symptoms are monitored. Reproduction of characteristic lower extremity symptoms during sustained extension supports the diagnosis of stenosis. The straight leg raise test, which is highly sensitive for lumbar disc herniation with nerve root compression, is characteristically negative in patients with lumbar spinal stenosis. This finding helps differentiate stenosis from disc herniation in patients presenting with radicular symptoms. A positive straight leg raise, meaning reproduction of radicular pain with passive hip flexion while the knee is extended, suggests disc herniation rather than stenosis as the primary pathology, though both conditions may coexist. The crossed straight leg raise, wherein straight leg raising on the asymptomatic side reproduces symptoms on the symptomatic side, is highly specific for disc herniation and is not expected in stenosis. The two-stage treadmill test provides a provocative assessment that can differentiate neurogenic from vascular claudication. The patient first walks on a leveled treadmill until symptoms develop. After recovery, the patient walks on an inclined treadmill at the same speed. Patients with neurogenic claudication demonstrate improved walking tolerance on the inclined surface due to the trunk flexion induced by uphill walking. Patients with vascular claudication demonstrate worse performance on the inclined surface due to the increased metabolic demand. While this test is not routinely performed in all clinical settings, it provides definitive differentiation when the diagnosis remains uncertain after standard evaluation. Several validated clinical prediction rules and scoring systems assist in the diagnosis of lumbar spinal stenosis and provide standardized approaches to assessment. These tools synthesize individual examination findings into composite scores with established diagnostic accuracy, supporting clinical decision-making and facilitating communication among providers. The N-class criteria, which stands for Nerve Root Compression Lumbar Assessment of Stenosis Syndrome, represent a validated clinical prediction rule that assists in identifying patients with lumbar spinal stenosis. The criteria incorporate 5 clinical features: age greater than 60 years, positive 30-second lumbar extension test, negative straight leg raise, bilateral leg symptoms, and symptom relief with sitting or lumbar flexion. The presence of 4 or more of these features demonstrates high specificity for the diagnosis of lumbar spinal stenosis. These criteria provide a standardized approach to clinical assessment that can be applied efficiently in routine practice and help guide decisions regarding the need for confirmatory imaging. Additional diagnostic algorithms have been proposed for lumbar spinal stenosis assessment. A comprehensive diagnostic and treatment algorithm published by Antony and colleagues provides a structured approach to patient evaluation that integrates clinical findings with imaging and guides subsequent management decisions. Such algorithms support consistent, evidence-based clinical practice and may be particularly valuable for clinicians who encounter stenosis patients less frequently. Validated outcome instruments provide standardized measures for quantifying symptom severity, functional limitation, and treatment response in patients with lumbar spinal stenosis. Selection of appropriate instruments requires understanding their measurement properties, clinical utility, and applicability to the stenosis population. A systematic review by DeLuca and colleagues examined outcome instruments used in randomized controlled trials of physical therapy for lumbar spinal stenosis, identifying considerable heterogeneity in measurement approaches and highlighting the need for standardization. The Oswestry Disability Index remains the most widely used measure of functional limitation in lumbar spine conditions, including spinal stenosis. This 10-item questionnaire assesses the impact of back and leg symptoms on activities including walking, sitting, standing, personal care, and social activities, generating a percentage score where higher values indicate greater disability. Research examining the psychometric properties of the Oswestry Disability Index in lumbar surgery patients has demonstrated good reliability, with Cronbach's alpha of 0.87 and intraclass correlation coefficient of 0.89, supporting its use for both baseline assessment and outcome monitoring. The minimal clinically important difference for the Oswestry Disability Index in stenosis populations is approximately 10 to 15 points, providing a benchmark for evaluating treatment response. Comparative research examining the Oswestry Disability Index, Roland Morris Disability Questionnaire, and Quebec Back Pain Disability Scale in older adults with low back pain found similar measurement properties across instruments, with the Oswestry Disability Index demonstrating Cronbach's alpha of 0.86, intraclass correlation, coefficient of 0.89, and smallest detectable change of 19.1 points. All three instruments demonstrated sufficient construct validity and responsiveness, suggesting that clinicians may select among them based on practical considerations such as administration time and patient preference. Pain assessment using the Visual Analog Scale or Numeric Pain Rating Scale provides complementary information to disability measures. Separate assessment of back pain and leg pain severity is recommended, as these symptoms may respond differently to treatment and have distinct prognostic implications. Walking capacity, typically assessed as self-reported comfortable walking distance or maximum walking distance before symptoms force cessation, provides a functional measure with high face validity that resonates with patients' daily life limitations. The differential diagnosis of lumbar spinal stenosis encompasses multiple conditions that may present with low back pain, lower extremity symptoms, or exercise-induced leg discomfort. Systematic consideration of alternative diagnoses is essential, particularly in older adults who may have multiple concurrent conditions. The consequences of misdiagnosis include delayed treatment of alternative conditions, inappropriate treatment of presumed stenosis, and failure to identify serious pathology requiring urgent intervention. Peripheral artery disease represents the most important differential diagnosis for neurogenic claudication, as both conditions produce exercise-induced leg symptoms in a similar patient population. Vascular claudication results from atherosclerotic narrowing of the lower extremity arteries, producing muscle ischemia during exertion. Key differentiating features include the location and character of symptoms, the relationship to posture, and the pattern of relief. Vascular claudication typically produces cramping pain in the calf muscles that begins predictably after a consistent walking distance, is not affected by posture, and resolves within 1 to 2 minutes of rest regardless of body position. Physical examination findings supporting vascular claudication include diminished or absent peripheral pulses, cool extremities, trophic skin changes, and arterial brutes. The ankle brachial index provides an objective measure of peripheral arterial perfusion, with values below 0.9 indicating arterial insufficiency. Coexistence of neurogenic and vascular claudication is common given the shared risk factors of age and cardiovascular disease. Patients with both conditions may present with mixed features that complicate diagnosis. In such cases, the two-stage treadmill test described earlier can help clarify the relative contribution of each condition, and vascular consultation may be indicated for comprehensive evaluation and management. Lumbar disc herniation produces radicular symptoms through direct compression of nerve roots by displaced nuclear material. Unlike the gradual exercise-induced onset of neurogenic claudication, radicular pain from disc herniation is typically present at rest, exacerbated by sitting and forward flexion, which are positions that increase intradiscal pressure and associated with a positive straight leg raise test. The symptom distribution follows a specific dermatomal pattern corresponding to the compressed nerve root, in contrast to the multi-level or non-dermatomal distribution common in central stenosis. Disc herniation tends to affect a younger population than stenosis, with peak incidence in the 4th and 5th decades of life, though the conditions may coexist in older patients with degenerative changes. Hip osteoarthritis may present with groin, lateral hip, thigh, or even knee pain that is provoked by walking, mimicking neurogenic claudication. Differentiating features include the location of pain, with groin and anterior thigh predominance in hip arthritis versus buttock, and posterior leg predominance in stenosis, reproduction of pain with hip range of motion testing, particularly internal rotation and flexion, and absence of neurological findings. The Faber test, which stands for flexion, abduction, and external rotation, and Fader test, which stands for flexion, adduction, and internal rotation, help identify hip joint pathology. Given the high prevalence of both hip osteoarthritis and lumbar spinal stenosis in older adults, concurrent diagnosis is common, and both conditions may contribute to functional limitation. Diabetic peripheral neuropathy produces sensory symptoms in the lower extremities that may overlap with stenosis presentation. The neuropathy typically produces symmetric distal stocking distribution symptoms that are constant rather than exercise-induced and are not relieved by postural change. Associated findings include diminished ankle reflexes, impaired vibration sense, and reduced protective sensation. The presence of established diabetes with poor glycemic control increases the likelihood of neuropathy as the primary diagnosis, though patients with both diabetes and stenosis are common in clinical practice. Recognition of clinical features suggesting serious underlying pathology is essential for patient safety. Cauda equina syndrome, characterized by bowel or bladder dysfunction, typically urinary retention, saddle anesthesia, and bilateral lower extremity weakness, represents a surgical emergency requiring immediate referral. Progressive motor weakness, particularly foot drop developing over days to weeks, suggests significant neural compromise that may warrant expedited surgical evaluation. Constitutional symptoms, including unexplained weight loss, fever, or night sweats, raise concern for malignancy or spinal infection. A history of cancer, immunosuppression, intravenous drug use, or recent spinal procedure increases the pretest probability of serious pathology. When red flags are identified, immediate medical referral should be arranged and rehabilitation treatment deferred until appropriate evaluation is completed. Diagnostic imaging plays an essential role in confirming the diagnosis of lumbar spinal stenosis, characterizing the location and severity of stenosis, and excluding alternative pathology. However, imaging findings must be interpreted in the context of clinical presentation, as structural abnormalities are common in asymptomatic individuals and do not independently indicate the need for treatment. Magnetic resonance imaging represents the preferred imaging modality for evaluation of lumbar spinal stenosis, providing detailed visualization of soft tissue structures including neural elements, intervertebral discs, and ligaments without ionizing radiation. MRI assessment of lumbar spinal stenosis evaluates central canal dimensions, lateral recess patency, and foraminal narrowing at each lumbar level. The degree of central canal stenosis is commonly graded based on the percentage reduction in cross-sectional area or the relationship between cerebrospinal fluid and neural elements. Mild stenosis demonstrates reduction of less than 1/3 of normal dimensions with cerebrospinal fluid still visible around the cauda equina. Moderate stenosis involves reduction of 1/3 to 2/3 with diminished but present cerebrospinal fluid signal, and severe stenosis demonstrates greater than 2/3 reduction with obliteration of cerebrospinal fluid signal and crowding of nerve roots. Recent research has validated novel ratio-based metrics for stenosis assessment, including the ratio between dural sac and disc cross-sectional areas, which demonstrated superior correlation with clinical symptoms and surgical outcomes compared to traditional measures. The correlation between MRI findings and clinical symptoms has been examined in multicenter research. Altan and colleagues found that while severe central canal stenosis generally correlated with more pronounced clinical symptoms, considerable individual variation existed, and some patients with radiographically severe stenosis demonstrated relatively preserved function. This discordance reinforces the clinical principle that imaging findings should confirm and characterize stenosis identified through clinical assessment rather than drive diagnosis and treatment in isolation. The fundamental principle guiding imaging interpretation in lumbar spinal stenosis is that structural findings acquire clinical significance only when correlated with appropriate symptoms and signs. Population-based studies consistently demonstrate that a substantial proportion of asymptomatic older adults have radiographic evidence of spinal stenosis, while some patients with classic neurogenic claudication show only modest structural changes. Treatment decisions should be based on the clinical syndrome rather than imaging findings alone, with imaging serving to confirm the suspected diagnosis, characterize the anatomical pattern of stenosis, and exclude alternative pathology. This principle applies equally to decisions regarding conservative management and surgical referral. We now transition to Module 3, which covers evidence-based rehabilitation protocols. Rehabilitation represents the cornerstone of conservative management for lumbar spinal stenosis, with substantial evidence supporting its effectiveness in reducing symptoms, improving function, and enhancing quality of life. Contemporary evidence-based rehabilitation protocols integrate multiple therapeutic modalities, including manual therapy, therapeutic exercise, aerobic conditioning, and patient education, into comprehensive treatment programs tailored to individual patient presentations. This module details the specific components of evidence-based rehabilitation, provides dosing parameters supported by clinical research, and establishes the scientific rationale underlying intervention selection for patients with neurogenic claudication. The evolution of rehabilitation approaches for lumbar spinal stenosis reflects advancing understanding of the condition's pathophysiology and biomechanics. Early interventions often borrowed generically from low back pain protocols, but contemporary practice recognizes that stenosis requires specifically targeted approaches that address the unique features of neurogenic claudication. The postural dependency of symptoms, with exacerbation in extension and relief in flexion, provides the biomechanical rationale for flexion-based exercise strategies that distinguish stenosis rehabilitation from treatment of other lumbar conditions. Integration of this pathophysiological understanding with evidence from randomized controlled trials and systematic reviews enables rehabilitation professionals to deliver optimally effective care. Systematic reviews and meta-analyses provide the highest level of evidence supporting rehabilitation effectiveness for lumbar spinal stenosis. The updated Cochrane-style systematic review by Amendolia and colleagues, published in BMJ Open in 2022, synthesized evidence from randomized controlled trials examining non-operative treatment approaches. This comprehensive analysis found moderate-quality evidence that supervised exercise programs reduce pain and improve function compared to usual care or no treatment. The review highlighted that multimodal programs combining multiple intervention components demonstrated more consistent benefits than single-modality approaches, supporting the comprehensive rehabilitation model detailed in this module. A systematic review by Comer and colleagues specifically examined the components of exercise interventions for lumbar spinal stenosis across published clinical trials. This analysis identified considerable heterogeneity in intervention design but found that effective programs typically incorporated flexion-based exercises, general conditioning, and manual therapy components. The review emphasized the need for standardized reporting of intervention parameters to facilitate clinical translation and replication of research findings. For rehabilitation professionals, this work provides guidance on essential program components, while acknowledging that optimal combinations and dosing continue to be refined through ongoing research. Temporidi and colleagues conducted a systematic review examining the effects of physical therapy specifically on pain and disability outcomes in lumbar spinal stenosis patients. Their analysis found that physical therapy interventions produced statistically significant and clinically meaningful improvements in both pain intensity and functional disability. Effect sizes were generally moderate, comparable to those achieved with other conservative interventions and supportive of physical therapy as first-line management. Importantly, the review found no serious adverse events associated with physical therapy interventions, establishing an excellent safety profile that contrasts favorably with surgical and pharmacological alternatives. The question of whether radiographic stenosis severity limits rehabilitation responsiveness has important implications for clinical decision-making. A recent analysis by Shahidi and colleagues directly addressed this question, finding that stenosis severity on imaging did not predict response to exercise-based rehabilitation. Patients across all severity grades, mild, moderate, and severe, demonstrated similar patterns of improvement with appropriate intervention. This finding supports offering comprehensive rehabilitation to all patients with symptomatic stenosis, regardless of imaging severity, and challenges assumptions that severe structural narrowing precludes meaningful conservative treatment response. The delivery model for rehabilitation significantly influences treatment outcomes. Evidence consistently demonstrates that supervised exercise programs produce superior results compared to unsupervised home exercise or general advice to remain active. Supervised programs provide multiple advantages, ensuring correct exercise technique, enabling appropriate progression, identifying and addressing barriers to adherence, and providing the accountability and motivation that support sustained participation. The enhanced effectiveness of supervision justifies the additional healthcare resources required and should be communicated to patients, payers, and referring providers. Optimal supervision frequency appears to be twice weekly based on available evidence. This frequency provides sufficient contact to ensure proper technique and appropriate progression while allowing adequate recovery between sessions for physiological adaptation. Programs of 6 to 12 weeks duration demonstrate meaningful improvements in most outcome measures, though some patients may benefit from extended treatment. The initial supervised phase should transition to independent home exercise as patients demonstrate competence and symptom stability, with periodic reassessment to ensure continued progress and address emerging issues. Propensity score-matched analysis comparing supervised physical therapy to surgical intervention has provided valuable comparative effectiveness data. Minitama and colleagues found that patients receiving supervised physical therapy demonstrated improvements in pain, disability, and walking capacity that, while initially smaller than surgical improvements, showed substantial convergence over longer follow-up periods. These findings support the recommendation that comprehensive supervised rehabilitation should be offered as initial management for most patients, with surgical consultation reserved for those who fail to achieve adequate improvement or who present with features predicting poor conservative response. Manual therapy encompasses hands-on techniques including joint mobilization, soft tissue mobilization, and stretching performed by the treating clinician. For lumbar spinal stenosis, manual therapy serves multiple purposes: reducing pain and muscle guarding, improving segmental mobility, and preparing tissues for subsequent exercise. While manual therapy alone is insufficient for comprehensive stenosis management, its integration with exercise produces synergistic benefits that exceed either approach in isolation. Lumbar distraction techniques apply longitudinal traction forces that increase intervertebral space and reduce compression of neural elements. Manual distraction can be performed in prone, side-lying, or supine positions depending on patient tolerance and clinician preference. The mechanical effect of distraction, increasing the cross-sectional area of the spinal canal and neural foramina, directly addresses the pathophysiology of stenosis and often provides immediate, though temporary, symptom relief. This immediate response can enhance patient confidence and engagement with the broader rehabilitation program. Flexion-based mobilization techniques apply oscillatory or sustained forces that promote lumbar flexion at symptomatic segments. These techniques can be performed segmentally, targeting specific levels identified through clinical examination or regionally to address multiple segments. The physiological rationale parallels that of flexion exercises, promoting positions that increase canal dimensions and reduce neural compression. Mobilization grades and dosing should be individualized based on patient response, with typical protocols involving 5 to 10 repetitions per segment during each treatment session. Spinal manipulation, characterized by high-velocity, low-amplitude thrust techniques, has been examined as a component of multimodal rehabilitation for lumbar spinal stenosis. A randomized controlled trial by Young and colleagues evaluated the addition of spinal manipulation and dry needling to conventional physical therapy for lumbar spinal stenosis patients. The study found that patients receiving the combined intervention demonstrated greater improvements in pain and function compared to conventional physical therapy alone, supporting the integration of manipulation within comprehensive treatment programs for appropriate patients. The dosing of spinal manipulative therapy and its relationship to outcomes has been examined in large cohort studies. Anderson and colleagues analyzed insurance claims data from over 11,000 low back pain episodes and found that low-dose spinal manipulation, meaning one visit, was associated with 55% lower risk of escalation to more intensive spine care, while moderate-dose manipulation, meaning 2 to 12 visits, was associated with 42% lower risk. Interestingly, high-dose manipulation, meaning 13 or more visits, showed no protective effect, suggesting that moderate utilization produces optimal outcomes. These findings support integrating manipulation as one component of multimodal care rather than as a standalone extended treatment. Safety considerations for manual therapy in the stenosis population warrant attention. The elderly patients who comprise the majority of stenosis presentations may have osteoporosis, cardiovascular disease, or other conditions that influence technique selection and force application. Contraindications to high-velocity manipulation include severe osteoporosis, vertebral malignancy, infection, inflammatory arthropathy, and anticoagulation therapy. When contraindications exist, lower-grade mobilization techniques provide a safer alternative while still contributing to program effectiveness. Flexion-based exercises constitute the foundational exercise approach for lumbar spinal stenosis rehabilitation. The biomechanical rationale is straightforward. Lumbar flexion increases the cross-sectional area of the spinal canal and neural foramina, reducing compression of neural elements and improving perfusion to nerve roots. This postural effect explains the symptomatic relief patients experience with sitting and forward bending and provides the scientific basis for exercise prescription that emphasizes flexion positioning. The double-kneaded chest exercise represents the foundational flexion exercise for stenosis patients. Performed in supine with both knees drawn toward the chest, this exercise produces sustained lumbar flexion that increases canal dimensions and stretches the posterior spinal structures. The exercise should be performed with controlled movement, avoiding ballistic or jerking motions that may exacerbate symptoms. Typical dosing involves 8 to 10 repetitions with 10 to 20-second holds, performed twice daily as part of a home exercise program and incorporated into supervised treatment sessions. Single knee-to-chest exercises provide an alternative for patients who cannot tolerate bilateral flexion or who demonstrate asymmetric symptoms. The exercise is performed by drawing one knee toward the chest while the opposite leg remains extended or with the foot flat on the supporting surface. Alternating legs allows bilateral treatment while reducing the degree of lumbar flexion compared to the double knee-to-chest position. This modification is particularly useful as a starting point for patients with severe symptoms or limited flexibility. Posterior pelvic tilt exercises in supine position engage the abdominal muscles to flatten the lumbar lordosis against the supporting surface. While producing less extreme flexion than knee-to-chest exercises, posterior pelvic tilts develop the motor control and muscular endurance needed to maintain reduced lordosis during functional activities. The exercise should be performed with sustained holds of 5 to 10 seconds, progressing to longer durations as endurance improves. Integration of posterior pelvic tilt awareness into standing and walking represents a key functional progression. Seated lumbar flexion exercises progress the flexion program to more functional positions. The patient sits on a firm surface and flexes forward, reaching toward the floor or allowing the trunk to rest on the thighs. This position produces sustained lumbar flexion while incorporating the hip flexion that characterizes many daily activities. Seated flexion is often well tolerated because it approximates the postures patients naturally adopt for symptom relief. Holds of 20 to 30 seconds with 5 to 8 repetitions provide appropriate dosing for most patients. Standing flexion exercises provide the most functional progression, as they address the upright postures that typically provoke symptoms. The patient stands with feet shoulder-width apart and flexes forward at the hips and lumbar spine, reaching toward the floor or resting hands on a stable surface at knee or shin height. This exercise develops the flexibility and motor patterns needed to incorporate forward lean during symptomatic walking episodes. Standing flexion also serves as a self-management strategy that patients can employ during daily activities when symptoms arise. Quadruped positioning offers an intermediate level of lumbar loading while allowing controlled flexion movements. The cat-camel or cat-cow exercise alternates between lumbar flexion, rounding the back toward the ceiling, and extension, allowing the back to sag toward the floor, promoting segmental mobility and motor control. For stenosis patients, emphasis should be placed on the flexion phase, with the extension phase performed gently and within pain-free limits. Quadruped rocking, wherein the patient shifts the hips backward toward the heels while maintaining hand position, provides sustained flexion loading similar to the child's pose in yoga practice. Stretching protocols for lumbar spinal stenosis target muscle groups that influence lumbar posture and mobility. Tightness in the hip flexors promotes excessive lumbar lordosis, which reduces canal dimensions and may exacerbate symptoms. Hamstring tightness limits forward bending and may increase lumbar stress during reaching activities. Paraspinal muscle tightness contributes to movement restriction and may perpetuate postural dysfunction. Systematic stretching of these muscle groups complements flexion exercises and supports postural optimization. Hip flexor stretching targets the iliopsoas and rectus femoris muscles, which when tight produce anterior pelvic tilt and increased lumbar lordosis. The Thomas stretch position, with the patient supine at the edge of a treatment table with one hip flexed to the chest and the opposite leg hanging toward the floor, provides effective iliopsoas lengthening. The kneeling hip flexor stretch offers a more active alternative, with the patient in a half-kneeling position shifting weight forward to create hip extension on the trailing leg. A posterior pelvic tilt should be maintained during hip flexor stretching to prevent compensatory lumbar extension that would reduce stretch effectiveness and potentially aggravate symptoms. Hamstring stretching improves the ability to flex forward at the hips, reducing compensatory lumbar flexion demands during reaching and bending activities. Supine hamstring stretching with a strap or towel around the foot allows controlled stretching without requiring balance or producing lumbar extension. Seated hamstring stretching with one leg extended and the trunk flexing forward combines hamstring lengthening with the lumbar flexion positioning beneficial for stenosis. Stretches should be held for 20 to 30 seconds and repeated 2 to 3 times per leg, with daily performance recommended for optimal flexibility gains. Paraspinal muscle stretching overlaps substantially with flexion exercises, as positions that produce lumbar flexion inherently stretch the erector spine A and multifidus muscles. The double knee-to-chest position and child's pose in quadruped effectively lengthen the paraspinal muscles while providing the flexion-based symptom relief central to stenosis management. Gluteal stretching, including piriformis stretching in supine with the ankle crossed over the opposite knee, addresses tightness that may contribute to buttock symptoms and movement restriction. The Figure 4 stretch position should be performed bilaterally, with holds of 20 to 30 seconds. Trunk strengthening and stabilization exercises develop the muscular capacity to control lumbar posture during functional activities. The rationale for stabilization training in stenosis extends beyond general core strengthening. Patients must develop the ability to maintain positions of relative lumbar flexion during walking and standing, which requires both strength and motor control of the trunk musculature. Two broad categories of stabilization exercise, local segmental stabilization and global trunk stabilization, address different aspects of this functional requirement. Local segmental stabilization targets the deep trunk muscles, particularly the transversus abdominis and lumbar multifidus, that provide direct support to individual spinal segments. The abdominal drawing-in maneuver, wherein the patient gently draws the navel toward the spine without moving the pelvis or holding the breath, activates the transversus abdominis and establishes the foundation for segmental control. Research by Cyclang and colleagues demonstrated that core stabilization exercise with the abdominal drawing-in maneuver improved spinal posture, decreased pain, and reduced trunk muscle fatigue during prolonged sitting in patients with chronic low back pain. A systematic review by Smersina and colleagues examined the effectiveness of core stabilization exercises in non-specific low back pain, finding grade B evidence supporting their effectiveness for decreasing pain, improving function, and increasing core strength. While this review addressed low back pain broadly rather than stenosis specifically, the principles of segmental stabilization apply to stenosis patients who must control lumbar position during functional activities. Integration of drawing-in activation with functional movements, including sit-to-stand transfers, walking, and reaching, represents the ultimate goal of local stabilization training. Global trunk stabilization exercises target the larger, more superficial muscles including the rectus abdominis, external obliques, and erector spinae that generate and control trunk movement. These exercises develop the strength and endurance needed to maintain postural control during sustained activities. The bridge exercise, performed in supine with knees bent and hips lifted from the supporting surface, strengthens the gluteal muscles and posterior chain while maintaining a neutral or slightly flexed lumbar position. The modified plank or prone bridge, performed on forearms and toes with the trunk held in a straight line, challenges anterior and lateral trunk musculature. The bird dog exercise, performed in quadruped with alternating arm and leg extension, develops trunk control during movement and challenges both anterior and posterior stabilizers. For stenosis patients, the exercise should be modified to avoid excessive lumbar extension during leg lift. Cueing the patient to maintain a flat or slightly rounded lower back prevents symptom provocation. Progression parameters for global stabilization exercises typically involve 2 to 3 sets of 10 to 15 repetitions, performed 2 to 3 times weekly, with advancement to longer holds or added resistance as competence develops. Aerobic conditioning addresses the deconditioning that commonly develops secondary to activity limitation in stenosis patients. When walking becomes painful, patients naturally reduce their activity levels, leading to cardiovascular deconditioning, muscle atrophy, and weight gain that further compound functional limitation. Breaking this cycle requires aerobic exercise modalities that can be performed without provoking neurogenic claudication symptoms. The selection of appropriate modalities based on postural demands represents a key clinical decision in program design. Stationary cycling represents the ideal aerobic modality for most stenosis patients because the seated forward flex position maintains lumbar flexion throughout exercise. Patients who cannot walk one block often tolerate 30 minutes or more of cycling without symptom provocation, demonstrating the profound impact of posture on symptom generation. Cycling intensity can be progressed through duration, resistance, and cadence modifications, allowing individualized advancement based on cardiovascular and symptomatic response. Initial prescription typically involves 10 to 15 minutes at low to moderate intensity, progressing to 30 to 45 minutes as tolerance develops. Recumbent cycling and elliptical trainers with forward-leaning posture provide alternatives to upright cycling for patients who prefer variety or have difficulty with standard bicycle seats. The key principle across all cycling modalities is maintenance of a flexed lumbar posture that increases canal dimensions and prevents symptom provocation. Patients should be educated regarding this principle so they can identify and implement appropriate positioning on equipment encountered in community fitness settings. Treadmill walking, while potentially provocative of neurogenic claudication, can be incorporated through incline protocols that promote forward trunk lean. Walking on an inclined treadmill naturally induces the forward flexed posture that relieves symptoms, often allowing significantly longer walking duration than level ground ambulation. Body weight supported treadmill walking, using overhead harness systems that partially unload body weight, provides an additional modification for patients with severe limitation. Progressive reduction of body weight support and transition to unsupported incline walking, then level walking, represents a systematic advancement toward functional ambulation goals. Aquatic therapy provides unique advantages for stenosis rehabilitation through the physical properties of water immersion. Buoyancy reduces axial loading on the spine, hydrostatic pressure may reduce edema around neural elements, and water resistance allows strengthening exercise with minimal joint stress. The warm water environment typical of therapy pools promotes muscle relaxation and may reduce pain perception. For patients who cannot tolerate land-based exercise, aquatic therapy offers an alternative pathway to meaningful rehabilitation participation. A meta-analysis by Haidari and colleagues examined the effects of aquatic exercise on pain, disability, and quality of life in adults with low back pain. The analysis of 14 randomized controlled trials with 484 participants found that aquatic exercise significantly reduced pain intensity, with a mean difference of 3.82 points on standard pain scales. Disability showed improvement with a standardized mean difference of 1.65, and quality of life improved in both physical and mental component scores. These findings support aquatic therapy as an effective intervention for patients with low back conditions, including stenosis. The water study by Psycharakis and colleagues specifically examined which aquatic exercises increase muscle activity and limit pain for people with chronic low back pain. Analysis of 26 aquatic exercises found that hip abduction and extension movements increased gluteal muscle activity, squat variations increased back extensor activity, and exercises using buoyancy equipment increased abdominal muscle activity. Importantly, 17 of the 26 exercises were performed pain-free by the majority of participants, providing clinicians with a menu of well-tolerated options for program design. These findings enable evidence-based selection of aquatic exercises targeting specific muscle groups while minimizing symptom provocation. Aquatic therapy protocols for stenosis typically include pool walking in chest-deep water, which reduces spinal loading by approximately 50% compared to land ambulation. Flexion exercises including knee-to-chest movements and trunk curls can be performed using the pool wall or noodle floats for support. Lower extremity strengthening through squats, leg lifts, and step exercises take advantage of water resistance while minimizing joint stress. Session duration of 30 to 45 minutes performed 2 to 3 times weekly provides appropriate dosing for most patients. Transition from aquatic to land-based exercise should be gradual, with many patients benefiting from continued aquatic sessions even as they progress to land-based activities. Patient education constitutes an essential component of comprehensive stenosis rehabilitation, providing the knowledge and skills patients need for long-term self-management. Education addresses understanding of the condition, activity modification strategies, symptom management techniques, and maintenance exercise programming. The goal is developing patient self-efficacy, confidence in the ability to manage symptoms and maintain function that supports sustained benefit beyond the supervised treatment period. Research on patient education approaches for low back pain provides guidance for stenosis management. A randomized controlled trial by Ibrahim and colleagues found that patient education combined with motor control exercise produced greater improvements in pain and disability than either intervention alone. The combination approach reduced fear avoidance beliefs about physical activity and decreased pain medication use, suggesting that education enhances the effectiveness of exercise interventions through cognitive and behavioral mechanisms. Person-centered education approaches that address individual patient concerns and misconceptions appear more effective than generic educational content. Key educational content for stenosis patients includes explanation of the postural nature of symptoms and the rationale for flexion-based approaches, instruction in activity modification strategies that reduce symptom provocation, training in self-management techniques for symptom flares, and guidance on maintaining exercise programs independently. Patients should understand that stenosis is a manageable condition and that active participation in rehabilitation produces meaningful improvement for the majority of individuals. Setting realistic expectations while maintaining therapeutic optimism supports patient engagement and adherence to treatment recommendations. We now proceed to Module 4, which addresses advanced rehabilitation strategies and special populations. The population affected by lumbar spinal stenosis presents unique challenges that extend beyond the application of standard rehabilitation protocols. Older adults with stenosis frequently present with concurrent medical conditions, functional limitations, and psychosocial factors that influence treatment selection, response, and safety. This module addresses advanced rehabilitation strategies for complex presentations, examines the evidence regarding special populations including frail elderly patients and those with high comorbidity burden, and details adjunctive interventions including epidural steroid injections and prehabilitation approaches. Rehabilitation professionals who develop expertise in managing these complex presentations are positioned to optimize outcomes for the patients who most need skilled intervention. The demographic reality of lumbar spinal stenosis necessitates competence in geriatric rehabilitation principles. With peak incidence occurring in the 7th and 8th decades of life, stenosis patients frequently present with the accumulated medical complexity characteristic of advanced age. Cardiovascular disease, diabetes mellitus, osteoarthritis, osteoporosis, and cognitive impairment commonly coexist with stenosis and influence every aspect of rehabilitation planning. The rehabilitation professional must integrate condition-specific stenosis interventions with broader considerations of medical safety, fall risk, and functional capacity to deliver truly patient-centered care. Research examining age-related outcomes in lumbar spinal stenosis has produced encouraging findings that support active rehabilitation for patients across the age spectrum. A comparative study by Takase and colleagues examined surgical outcomes in patients aged 75 years and older compared to younger patients, finding that while elderly patients presented with higher rates of frailty, polypharmacy, and comorbidity burden at baseline, they still achieved meaningful functional improvements following intervention. This finding extends to conservative management, where older adults demonstrate responsiveness to rehabilitation that, while potentially slower in onset and smaller in magnitude than younger patients, remains clinically meaningful and valued by patients. The trajectory of recovery differs between age groups in ways that inform rehabilitation planning and patient counseling. Older patients may require longer treatment duration to achieve equivalent gains, necessitating extended supervised care and more gradual progression of exercise intensity. The rate of improvement during the initial weeks of treatment may be slower, requiring patience from both clinician and patient while maintaining confidence that continued participation will yield benefit. Setting appropriate expectations at treatment initiation, acknowledging that improvement may develop more gradually while affirming that meaningful gains are achievable, supports patient engagement and adherence through the early treatment phase when observable progress may be limited. Functional outcome goals should be individualized based on patient priorities and realistic capacity. While a younger patient might target return to recreational sports or prolonged walking for exercise, an elderly patient may prioritize independence in household ambulation, ability to participate in family activities, or maintenance of community mobility. These patient-centered goals, while different in absolute terms, are equally valid rehabilitation targets and may be more readily achievable for older patients than goals derived from younger populations. The use of goal attainment scaling or similar individualized outcome approaches can capture meaningful improvement that might not register on standardized instruments normed to younger populations. Frailty represents a state of decreased physiological reserve and increased vulnerability to stressors that predicts adverse outcomes across medical and surgical interventions. In the context of lumbar spinal stenosis, frailty status influences treatment tolerance, recovery trajectory, and outcome expectations. Research by Nagai and colleagues examined the association between frailty and locomotive syndrome in patients with lumbar spinal stenosis, finding significant relationships between frailty measures and functional limitation that inform rehabilitation planning. Patients meeting criteria for frailty demonstrated worse baseline function and faced greater challenges in rehabilitation participation, though they remained capable of meaningful improvement with appropriately modified intervention. The impact of frailty on surgical outcomes has been documented in recent research. Sugimoto and colleagues found that frail patients undergoing surgery for lumbar spinal stenosis demonstrated worse postoperative outcomes compared to non-frail patients, though the difference was attributable primarily to worse baseline status rather than differential response to intervention. This finding has important implications for treatment selection. Frail patients may benefit from exhaustive, conservative treatment trials before considering surgical intervention, and those who do proceed to surgery require intensive perioperative rehabilitation support to optimize outcomes. Frailty screening should be incorporated into the initial evaluation of elderly stenosis patients to inform treatment planning. Simple screening tools including gait speed measurement, grip strength assessment, and questionnaire-based instruments can identify patients at increased risk who may benefit from modified treatment approaches. Gait speed below 0.8 meters per second, grip strength below established age and sex norms, and positive responses on frailty screening questionnaires warrant consideration of enhanced supervision, reduced initial exercise intensity, and extended treatment duration. Importantly, frailty is potentially modifiable through appropriate intervention, and rehabilitation itself may contribute to improved frailty status over time. The cumulative burden of comorbid conditions represents one of the strongest predictors of functional outcome in lumbar spinal stenosis, exceeding the predictive value of stenosis severity, symptom duration, or demographic factors. Patients with multiple concurrent medical conditions face compounded functional limitations, reduced physiological reserve for exercise participation, and increased risk of adverse events during treatment. Systematic assessment of comorbidity burden at treatment initiation enables appropriate program modification and realistic outcome prognostication. Cardiovascular disease commonly coexists with lumbar spinal stenosis given shared risk factors of advanced age, sedentary lifestyle, and metabolic dysfunction. The presence of coronary artery disease, heart failure, or arrhythmia influences aerobic exercise prescription and necessitates appropriate monitoring during treatment sessions. Exercise intensity should be guided by cardiovascular symptoms and, when available, results of cardiac stress testing. Rate pressure product monitoring provides an objective measure of cardiac workload during exercise, with target ranges individualized based on cardiac status. Patients with significant cardiovascular disease benefit from communication between rehabilitation and cardiology providers to ensure coordinated, safe care. Diabetes mellitus affects stenosis rehabilitation through multiple mechanisms. Diabetic peripheral neuropathy may contribute to lower extremity symptoms that overlap with or mask neurogenic claudication, complicating assessment of stenosis-specific treatment response. Impaired wound healing and infection susceptibility influence surgical candidacy and postoperative care. Glycemic control may fluctuate with changes in activity level, requiring coordination with diabetes management providers. Exercise timing relative to meals and insulin administration requires attention to prevent hypoglycemia during treatment sessions. Despite these challenges, exercise remains beneficial for diabetic patients and may contribute to improved glycemic control alongside stenosis-specific outcomes. Concurrent osteoarthritis of the hips, knees, or other joints frequently accompanies lumbar spinal stenosis in elderly patients. This combination of conditions produces additive or synergistic functional limitation, as impairments in multiple body regions compound walking difficulty beyond what either condition would produce in isolation. Rehabilitation programs must address both spinal and peripheral joint contributions to functional limitation, incorporating joint protection strategies, appropriate exercise modification, and potentially assistive device prescription. Aquatic therapy offers particular advantages for patients with concurrent stenosis and lower extremity osteoarthritis, as buoyancy reduces joint loading while allowing meaningful exercise participation. Polypharmacy, defined as concurrent use of 5 or more medications, is prevalent in the elderly stenosis population and has been associated with worse rehabilitation outcomes. Research by Kawabata and colleagues found that hyperpolypharmacy involving 10 or more medications had significant negative impact on surgical outcomes in lumbar spinal stenosis patients. The mechanisms underlying this association likely include increased fall risk from sedating or hypotensive medications, drug interactions affecting exercise tolerance, and the general marker of medical complexity that extensive medication regimens represent. Medication review in collaboration with pharmacy and primary care providers may identify opportunities for deprescribing that could improve rehabilitation participation and outcomes. Psychological factors including fear avoidance beliefs, catastrophizing depression and anxiety influence pain perception, treatment engagement, and functional outcomes in lumbar spinal stenosis. Psychologically informed practice integrates recognition and management of these factors into rehabilitation care, moving beyond purely biomechanical approaches to address the cognitive and emotional dimensions of the pain experience. This approach does not require rehabilitation professionals to function as mental health providers, but rather to incorporate psychological principles into their existing scope of practice. Fear avoidance beliefs, the conviction that activity will cause harm or worsen the underlying condition, represent a particularly important target in stenosis rehabilitation. Patients who believe that walking will damage their spine or accelerate deterioration may avoid beneficial activity, perpetuating deconditioning and functional decline. Addressing these beliefs through education about the safety of appropriate exercise, graduated exposure to feared activities, and positive reinforcement of activity participation can reduce fear avoidance and improve engagement with rehabilitation. The evidence that exercise does not worsen stenosis and may provide durable benefit should be explicitly communicated to patients harboring concerns about activity safety. Self-efficacy, confidence in one's ability to perform specific behaviors and manage symptoms, predicts exercise adherence and functional outcomes in chronic pain conditions including stenosis. Rehabilitation approaches that build self-efficacy through mastery experiences, verbal encouragement, and observation of peer success support sustained behavior change. Structured self-management programs that teach problem-solving skills for symptom flares, provide tools for independent exercise progression, and build confidence in activity participation, promote long-term success beyond the supervised treatment period. Patient education approaches emphasizing patient capability and control over their condition support self-efficacy development. Epidural steroid injections represent an adjunctive intervention that may facilitate rehabilitation participation by reducing pain and inflammation around compressed neural elements. Understanding the evidence regarding injection effectiveness enables rehabilitation professionals to counsel patients appropriately and coordinate care with interventional pain providers. The role of injections in stenosis management has been clarified by recent systematic reviews that inform clinical decision-making. A comprehensive systematic review by Arman and colleagues, published as an American Academy of Neurology Guidelines Subcommittee report in 2025, synthesized evidence from 90 randomized controlled trials examining epidural steroid injection effectiveness. For lumbar spinal stenosis specifically, the review found that epidural steroid injections possibly reduce short-term disability, with a success rate difference of 26.2% and number needed to treat of 4. Long-term disability reduction was also possible, with a success rate difference of 11.8% and number needed to treat of 8. However, the review found insufficient evidence that injections reduce short-term or long-term pain in stenosis patients. These findings suggest modest benefit for functional outcomes while highlighting limitations in pain reduction. Clinical research has examined factors that predict injection response and inform patient selection. A study by Kim and colleagues found that patients with moderate stenosis demonstrated greater improvement in pain scores and walking distance following epidural steroid injection compared to patients with severe stenosis. This finding suggests that injections may be most beneficial earlier in the disease course, before advanced structural changes limit treatment response. The clinical implication is that timely referral for injection consideration, rather than reserving injections as a last resort, may optimize outcomes for appropriate candidates. From a rehabilitation perspective, epidural steroid injections may create a window of reduced symptoms that facilitates more aggressive exercise participation. Patients who achieve pain reduction following injection can often tolerate higher exercise intensity, longer duration aerobic conditioning, and more rapid progression than their pre-injection baseline allowed. Coordinating rehabilitation intensification with the period of maximal injection benefit, typically the first 4 to 6 weeks following injection, may optimize the combined effect of these interventions. Communication with the interventional provider regarding injection timing relative to rehabilitation scheduling supports this coordinated approach. Prehabilitation, structured exercise and education programs delivered before surgical intervention has emerged as a strategy to optimize surgical outcomes by improving preoperative functional status and physiological reserve. For lumbar spinal stenosis patients proceeding to surgical decompression, prehabilitation may enhance postoperative recovery trajectories, reduce complications, and improve ultimate functional outcomes. The concept extends rehabilitation principles upstream from their traditional postoperative application to the preoperative period. A systematic review and meta-analysis by Panus and colleagues examined prehabilitation for patients undergoing orthopedic surgery, including spinal procedures. The review found that prehabilitation programs were associated with improved postoperative outcomes, including reduced pain, shorter hospital stays, and faster return to function. While the evidence base specific to lumbar stenosis surgery is still developing, the general principles of prehabilitation, improving aerobic capacity, strengthening key muscle groups, optimizing nutritional status, and addressing modifiable risk factors, apply to this population. Prehabilitation program components for stenosis surgical candidates should include aerobic conditioning using modalities tolerable given stenosis symptoms, such as cycling or aquatic exercise. Strengthening exercises targeting the trunk and lower extremity muscles that support postoperative mobility. Education regarding postoperative expectations, activity guidelines, and rehabilitation protocols. And optimization of modifiable health factors including smoking cessation, glycemic control, and nutritional status. Programs of 4 to 8 weeks duration appear sufficient to produce meaningful physiological adaptation while remaining practical within typical surgical scheduling timelines. While this course focuses primarily on conservative management, rehabilitation professionals frequently treat patients following surgical decompression for lumbar spinal stenosis. Understanding evidence-based approaches to post-surgical rehabilitation enables optimal care for these patients and supports communication with surgical colleagues regarding rehabilitation planning. A systematic review and meta-analysis by Mani and colleagues examined rehabilitation after surgical treatment for lumbar spinal stenosis, providing evidence-based guidance for postoperative care. The goals of post-surgical rehabilitation evolve across the recovery timeline. In the early postoperative phase, typically the first 2 to 4 weeks, rehabilitation focuses on wound protection, pain management, basic mobility training, and patient education regarding activity guidelines and precautions. Gentle range of motion exercises and walking programs are initiated within surgical guidelines, with progression guided by symptom response and tissue healing timelines. The intermediate phase, from approximately 4 to 12 weeks postoperatively, introduces progressive strengthening, aerobic conditioning, and functional training as tissue healing permits more vigorous activity. The long-term phase of post-surgical rehabilitation, extending from 3 months to 1 year or longer, focuses on optimizing functional outcomes, addressing residual impairments, and establishing sustainable exercise habits. Patients who have undergone decompression surgery may continue to experience some symptoms, particularly if preoperative duration was prolonged or neurological changes were present. Realistic counseling regarding expected outcomes supports patient satisfaction and continued engagement with rehabilitation. The evidence that approximately 1/3 of surgical patients report treatment non-success at long-term follow-up underscores the importance of comprehensive rehabilitation to optimize results even following technically successful surgery. Research examining predictors of post-surgical outcomes has identified factors that rehabilitation professionals should consider. The study by Wesselink and colleagues found that preoperative lumbar multifidus, intramuscular fat content of 50% or greater, was associated with significantly worse 5-year outcomes following decompression. This finding suggests that paraspinal muscle quality influences recovery capacity and may identify patients requiring more intensive post-operative rehabilitation support. Assessment of paraspinal muscle status through imaging review, when available, can inform rehabilitation intensity and outcome expectations. Postural and ergonomic interventions extend rehabilitation principles into patients' daily activities, supporting symptom management throughout the day rather than only during treatment sessions. Education regarding postures that increase and decrease symptoms enables patients to make informed activity choices and implement self-management strategies. Environmental modifications and assistive device prescription can substantially reduce symptom burden for patients with significant functional limitation. Activity modification strategies derive from understanding the postural dependency of neurogenic claudication. Patients should be educated that activities performed in lumbar flexion are generally better tolerated than those requiring extension or neutral posture. Specific recommendations include using a shopping cart, even for small purchases, to enable forward lean during store navigation, selecting chairs with adequate seat depth and height to support flexed sitting postures, positioning work surfaces to allow forward lean during standing tasks, and taking seated rest breaks during prolonged walking activities. These simple modifications can substantially extend functional tolerance without requiring additional medical intervention. Assistive device prescription may benefit patients with significant walking limitation. Rolling walkers with seats allow patients to walk with forward trunk lean supported by the walker frame, and the seat enables rest breaks without requiring the patient to find available seating. Canes provide more modest support but may reduce lower extremity loading and improve balance confidence for patients with mild to moderate limitation. The decision to prescribe assistive devices involves balancing the functional benefit against potential deconditioning from device dependence and patient acceptance of visible disability aids. Many patients benefit from having devices available for longer outings while continuing to ambulate independently for shorter household distances. Safe delivery of rehabilitation for complex elderly patients requires systematic attention to potential adverse events and appropriate monitoring protocols. While exercise-based rehabilitation for lumbar spinal stenosis demonstrates an excellent safety profile in research settings, the medical complexity of typical clinical populations necessitates vigilant monitoring and clear protocols for managing concerning findings. Baseline risk stratification should identify patients requiring enhanced monitoring or modified treatment approaches. Cardiovascular risk factors, fall history, osteoporosis status, and medication profiles all influence exercise safety and inform monitoring intensity. Patients with significant cardiovascular disease warrant vital sign monitoring during exercise, with established parameters for exercise modification or termination based on blood pressure, heart rate, or symptom response. Patients with high fall risk benefit from close supervision during standing and walking activities, use of gait belts, and exercise modification to reduce balance challenge while building strength and confidence. Recognition of warning signs requiring medical referral protects patient safety and ensures timely intervention for serious developments. New or progressive neurological deficits, particularly motor weakness or bowel and bladder changes, require urgent surgical evaluation as they may indicate cauda equina syndrome or progressive neural compromise. Constitutional symptoms including fever, unexplained weight loss, or night sweats warrant investigation for underlying malignancy or infection. Failure to progress as expected or unexplained symptom worsening should prompt reconsideration of the diagnosis and potential imaging or specialty consultation. Clear communication pathways with referring providers and established protocols for urgent referral support, timely response to concerning developments. We now arrive at Module 5, which covers outcomes, prognosis, and clinical decision-making. Clinical decision-making in lumbar spinal stenosis requires integration of outcome evidence, prognostic factors, and patient preferences into individualized treatment recommendations. The choice between continued conservative management and surgical referral represents one of the most consequential decisions facing patients and clinicians, with substantial implications for symptom trajectory, functional capacity, and quality of life. This module synthesizes comparative effectiveness evidence, identifies predictors of treatment response, and provides a framework for shared decision-making that supports optimal outcomes for individual patients. The evidence base informing stenosis treatment decisions has expanded substantially in recent years, with high-quality randomized controlled trials and systematic reviews clarifying the comparative effectiveness of rehabilitation and surgical approaches. Importantly, this evidence challenges simplistic assumptions that surgery provides uniformly superior outcomes, instead revealing a nuanced picture in which treatment selection should be individualized based on patient characteristics, preferences, and clinical presentation. Rehabilitation professionals who understand this evidence can counsel patients accurately and participate meaningfully in multidisciplinary treatment planning. The comparative effectiveness of rehabilitation versus surgical decompression for lumbar spinal stenosis has been examined in multiple randomized controlled trials and observational studies, with findings that inform treatment selection and patient counseling. The landmark Spine Patient Outcomes Research Trial, known as SPORT, provided foundational evidence regarding treatment outcomes, though interpretation is complicated by high rates of crossover between treatment groups. More recent trials and systematic reviews have further clarified the relative benefits and limitations of each approach across different time horizons. In the short term, typically defined as outcomes measured at 3 to 12 months following treatment initiation, surgical decompression generally produces greater improvements in pain and function compared to conservative management. The magnitude of surgical advantage varies across studies, but typically ranges from 7 to 13 points on the SF-36 bodily pain scale and 8 to 9 points on physical function measures. Oswestry Disability Index improvements favor surgery by approximately 9 to 12 points at 2 to 4 year follow-up. These differences exceed minimal clinically important difference thresholds and represent meaningful functional gains for surgical patients. However, the short-term surgical advantage must be contextualized within the broader treatment trajectory. Conservative management also produces significant improvement in the majority of patients, with systematic reviews demonstrating that supervised rehabilitation reduces pain and improves function compared to usual care or no treatment. The relevant comparison is not surgery versus no improvement, but rather the incremental benefit of surgery over active rehabilitation. For patients who respond well to conservative treatment, the additional benefit of surgery may not justify the associated risks, costs, and recovery demands. Perhaps the most important finding from longitudinal outcome research is the convergence of surgical and conservative treatment outcomes over extended follow-up periods. While surgery produces greater short-term improvement, this advantage diminishes progressively over time, with outcomes becoming statistically indistinguishable by 6 to 8 years following treatment. This convergence phenomenon has been observed across multiple trials and outcome measures, suggesting it represents a robust finding rather than an artifact of individual study design. The mechanisms underlying outcome convergence likely involve both continued improvement in conservatively managed patients and some deterioration in surgical patients over time. Natural history studies indicate that approximately 1/3 of stenosis patients improve spontaneously without intervention, suggesting that extended conservative management allows time for spontaneous recovery in responsive individuals. Simultaneously, surgical patients may experience adjacent segment degeneration, recurrent stenosis, or other late complications that erode initial surgical gains. The net result is functional equivalence at long-term follow-up despite divergent early trajectories. These findings have profound implications for treatment counseling. Patients seeking rapid symptom relief who are willing to accept surgical risks may reasonably choose operative intervention, while patients who prefer to avoid surgery and can tolerate a more gradual recovery trajectory may achieve equivalent long-term outcomes through comprehensive rehabilitation. Neither choice is inherently superior. Rather, the optimal decision depends on individual patient values and circumstances. When surgical intervention is indicated, the choice of surgical approach influences outcomes, recovery trajectory, and complication risk. The fundamental surgical goal is decompression of neural elements through removal of the structures causing stenosis, including hypertrophied ligamentum flavum, osteophytes, and portions of the facet joints. Whether this decompression should be accompanied by spinal fusion has been a subject of considerable research and debate, with recent high-quality evidence informing current recommendations. The question of whether fusion should accompany decompression in patients with degenerative spondylolisthesis has been addressed by multiple recent studies with remarkably consistent findings. A systematic review and meta-analysis by Gajraj and colleagues examined high-quality studies comparing decompression alone versus decompression with fusion for degenerative spondylolisthesis, finding no significant difference in clinical outcomes between approaches. This finding challenges historical assumptions that spinal instability from spondylolisthesis necessitates fusion to achieve satisfactory results. The 5-year follow-up results from the Nordsten DS randomized controlled trial, published by Komatsu and colleagues in the BMJ in 2024, provide definitive long-term evidence. This rigorously designed trial randomized patients with degenerative spondylolisthesis to decompression alone or decompression plus fusion with blinded outcome assessment. At 5 years, the trial found no significant difference between groups in the primary outcome of Oswestry Disability Index score, with both groups demonstrating substantial and durable improvement. Secondary outcomes, including leg pain, back pain, and quality of life, similarly showed no between-group differences. These findings support decompression alone as the preferred surgical approach for most patients with stenosis and spondylolisthesis, avoiding the increased operative time, blood loss, and complication risk associated with fusion procedures. A meta-analysis by Cheng and colleagues further confirmed these findings across multiple studies examining single-level lumbar spinal stenosis with spondylolisthesis. The pooled analysis found equivalent clinical outcomes between decompression alone and decompression plus fusion, with decompression alone demonstrating advantages in operative time, blood loss, and complication rates. These consistent findings across systematic reviews and randomized trials have shifted clinical practice toward decompression alone as the standard approach, with fusion reserved for specific indications such as high-grade spondylolisthesis or gross instability. Minimally invasive surgical techniques for lumbar stenosis decompression have evolved substantially, with endoscopic approaches gaining increasing utilization. Unilateral biportal endoscopy represents one such technique that allows decompression through 2 small incisions using endoscopic visualization. A meta-analysis by Zhuang and colleagues compared unilateral biportal endoscopy to microendoscopic decompression, finding comparable clinical outcomes with potential advantages in visualization and instrument maneuverability. Park and colleagues have described the technical aspects and outcomes of unilateral biportal endoscopy, demonstrating its safety and effectiveness for appropriately selected patients. The advantages of minimally invasive approaches include reduced tissue trauma, decreased blood loss, shorter hospital stays, and faster initial recovery compared to traditional open surgery. However, these techniques have longer learning curves, may have higher rates of incomplete decompression in early surgeon experience, and are not appropriate for all anatomical presentations. The choice between open and minimally invasive approaches should be individualized based on patient anatomy, surgeon expertise, and patient preferences regarding recovery trajectory. Identification of factors that predict response to conservative versus surgical treatment enables more precise treatment selection and supports realistic outcome counseling. Research has identified clinical, demographic, and radiographic factors associated with differential treatment response, though prediction at the individual level remains imperfect. Patients most likely to respond favorably to conservative management share several characteristics. Mild to moderate symptom severity at baseline predicts better conservative outcomes, likely reflecting earlier disease stage with greater capacity for improvement. Symptom duration of less than 1 year is associated with better rehabilitation response, while prolonged symptoms may indicate more advanced structural changes or established neural dysfunction less amenable to conservative intervention. Preserved walking capacity, typically operationalized as ability to walk more than 100 meters before symptom onset, indicates less severe functional compromise and predicts better conservative outcomes. Radiographic severity, interestingly, does not reliably predict conservative treatment response. The study by Shahidi and colleagues demonstrated that patients across all severity grades, mild, moderate, and severe, showed similar responsiveness to exercise-based rehabilitation. This finding supports offering comprehensive conservative treatment to all patients regardless of imaging findings, challenging assumptions that severe structural narrowing precludes meaningful rehabilitation benefit. Patient willingness to actively participate in rehabilitation, absence of significant psychological comorbidity, and realistic expectations regarding treatment timeline also favor conservative management success. Conversely, certain factors predict better outcomes with surgical intervention and may support earlier surgical referral. Severe or rapidly progressive symptoms, particularly motor weakness or cauda equina symptoms, indicate significant neural compromise that may not resolve with conservative management. High radiological grade of compression with severe central stenosis and obliteration of cerebrospinal fluid signal predicts less favorable conservative response. Walking capacity less than 100 meters before symptom onset indicates advanced functional limitation that may benefit from surgical decompression. Failure of adequate conservative treatment represents an important surgical indication. However, adequate conservative treatment requires sufficient intensity and duration to constitute a valid trial. Brief or unsupervised exercise programs do not constitute adequate trials of conservative care, and patients who fail such limited interventions may still respond to comprehensive supervised rehabilitation. Generally, a minimum of 6 to 12 weeks of supervised multimodal rehabilitation should be attempted before concluding that conservative management has failed. Research by Ding and colleagues specifically examined predictors of conservative treatment failure in lumbar spinal stenosis. Their analysis identified several factors associated with progression to surgery despite conservative management, including caudal foraminal stenosis location and positive straight leg raise testing. These findings can help identify patients at higher risk of conservative treatment failure who may benefit from closer monitoring or earlier consideration of surgical alternatives. The safety profiles of rehabilitation and surgical management differ substantially and represent important considerations in treatment selection. Comprehensive rehabilitation for lumbar spinal stenosis demonstrates an excellent safety record, with systematic reviews reporting only transient musculoskeletal soreness as a consistent adverse effect. No serious adverse events attributable to rehabilitation interventions have been reported in high-quality clinical trials. This favorable safety profile enables rehabilitation to be offered broadly, including to elderly patients with significant comorbidity who might face elevated surgical risks. Surgical decompression, while generally safe when performed by experienced surgeons, carries meaningful complication risk. Reported complication rates range from 10 to 24% depending on patient population, surgical approach, and definition of complications. Complications include wound infection, dural tear with cerebrospinal fluid leak, nerve root injury, hematoma formation, medical complications such as deep vein thrombosis and pneumonia, and general anesthesia-related events. Elderly patients with multiple comorbidities face elevated surgical risk, making careful patient selection essential. Reoperation rates following initial surgical decompression represent another important consideration. Published reoperation rates range from 4 to 23% at 10-year follow-up, reflecting recurrent stenosis, adjacent segment degeneration, and other late surgical failures. Patients should understand that initial surgery does not guarantee permanent symptom resolution, and that additional procedures may be required over time. This reality further supports the recommendation to attempt comprehensive conservative management before proceeding to surgery, as successful conservative treatment avoids both initial surgical risks and the possibility of future reoperation. Clinical practice guidelines from multiple professional organizations have synthesized the evidence regarding lumbar spinal stenosis management into actionable recommendations. A systematic comparison of clinical practice guidelines by Joe and colleagues examined recommendations across different guidelines, finding general consensus on several key points while noting areas of ongoing uncertainty. Guidelines consistently recommend comprehensive conservative management as initial treatment for most patients, with surgical intervention reserved for those with severe or progressive neurological deficits, intractable symptoms despite conservative care, or patient preference following informed decision-making. The Dutch Physiotherapy Guideline for Low Back Pain, detailed by Apeldoorn and colleagues, provides specific recommendations for rehabilitation management that apply to stenosis patients. The guideline emphasizes supervised exercise, patient education, and graded activity progression as core treatment components. Passive modalities, including manual therapy, are recommended as adjuncts to active exercise rather than standalone treatments. The guideline supports individualized treatment planning based on patient presentation and preferences, consistent with the shared decision-making framework appropriate for this patient population. Shared decision-making represents the optimal approach to treatment selection in lumbar spinal stenosis, integrating clinical evidence with patient values and preferences to reach individualized treatment decisions. This approach recognizes that the best treatment varies among patients depending on their priorities, risk tolerance, and life circumstances. The rehabilitation professional's role in shared decision-making involves presenting accurate information about treatment options and outcomes, eliciting patient preferences and concerns, and supporting deliberation that leads to decisions aligned with patient values. Key information that patients need to make informed decisions includes the expected outcomes of both conservative and surgical management, including the convergence of long-term outcomes, the timeline for improvement with each approach, acknowledging faster initial improvement with surgery, but substantial improvement achievable through rehabilitation, the safety profiles of each approach, including surgical complication and reoperation rates, and the factors that predict better or worse response to each treatment. This information should be presented in understandable terms, avoiding both excessive optimism and unwarranted pessimism about either treatment approach. Patient factors to explore in the decision-making discussion include functional priorities and the activities most important to maintain or restore, timeline preferences, and tolerance for gradual versus rapid improvement, risk tolerance and concerns about surgical complications, previous experiences with surgery or rehabilitation that may influence current preferences, and practical considerations including transportation for rehabilitation appointments, support for surgical recovery, and insurance coverage for different treatment approaches. Understanding these individual factors enables truly patient-centered recommendations. The outcome of shared decision-making should be a treatment plan that the patient understands, accepts, and is committed to following. For many patients, this will involve a trial of comprehensive conservative management with clear benchmarks for evaluating response and criteria for considering surgical referral if conservative treatment proves insufficient. For others, particularly those with severe symptoms, rapid progression, or strong preference for definitive intervention, earlier surgical referral may be appropriate. Either decision, made through an informed shared decision-making process, represents good clinical care. We now conclude with Module 6, which presents case studies illustrating clinical application and decision-making. The following case studies illustrate the application of evidence-based principles to diverse clinical presentations of lumbar spinal stenosis. Each case presents a unique combination of patient characteristics, clinical findings, and treatment considerations that rehabilitation professionals encounter in practice. The cases demonstrate systematic clinical reasoning, intervention selection based on current evidence, and outcome monitoring using validated instruments. References to preceding modules and the supporting literature are integrated throughout to reinforce the connection between research evidence and clinical application. Our first case study presents classic neurogenic claudication in an active older adult. Margaret is a 68-year-old retired elementary school teacher who presents with a 6-month history of progressive bilateral leg symptoms that have significantly limited her walking capacity. She describes aching pain and numbness in both buttocks and posterior thighs that develops after walking approximately 2 blocks and forces her to stop and rest. She has noticed that leaning forward on her shopping cart provides relief and allows her to continue walking much longer than when walking upright on the street. Sitting relieves her symptoms within 2 to 3 minutes, after which she can resume walking until symptoms recur. She denies bowel or bladder changes, saddle anesthesia, or night pain. Her goal is to return to her twice-weekly walking group and maintain her independence in community activities. Physical examination reveals a woman in no acute distress with mildly stooped standing posture and reduced lumbar lordosis. Gait observation demonstrates slightly reduced stride length and forward trunk lean. Lumbar range of motion shows full flexion without symptom provocation and extension limited to approximately 50% of normal, with reproduction of bilateral posterior thigh discomfort. The 30-second lumbar extension test reproduces her typical leg symptoms bilaterally. Straight leg raise testing is negative at 70 degrees bilaterally. Neurological examination demonstrates intact sensation to light touch in all lower extremity dermatomes, 5 out of 5 strength throughout bilateral lower extremities, and symmetric reflexes at the patella and Achilles. Peripheral pulses are strong and symmetric, and the ankle brachial index is 1.05 bilaterally, ruling out significant peripheral arterial disease. Applying the N-class clinical prediction criteria, Margaret demonstrates 4 of 5 features: age greater than 60 years, positive 30-second extension test, negative straight leg raise, and relief with sitting. This clinical presentation is highly consistent with lumbar spinal stenosis with neurogenic claudication. MRI of the lumbar spine obtained prior to her physical therapy referral demonstrates moderate central canal stenosis at L4-L5, with ligamentum flavum hypertrophy and facet arthropathy, correlating well with her clinical presentation. Margaret's baseline Oswestry Disability Index score is 38%, and she rates her average leg pain as 6 out of 10 on the numeric pain rating scale. Her comfortable walking distance is approximately 200 meters. Given her classic presentation, preserved neurological function, and motivated participation, she is an excellent candidate for comprehensive conservative management. Her treatment program consists of twice-weekly supervised sessions over 8 weeks incorporating manual therapy, flexion-based exercises, trunk stabilization, and aerobic conditioning. Manual therapy includes lumbar distraction mobilization and flexion-based joint mobilization at L4-L5, performed for 5 to 8 repetitions each session. Her home exercise program emphasizes double knee-to-chest exercises with 20-second holds performed twice daily, seated lumbar flexion stretches, hip flexor stretching in the Thomas test position, and posterior pelvic tilt training. Core stabilization progresses from supine abdominal drawing-in maneuvers to bridges and modified planks as her tolerance improves. Aerobic conditioning begins with stationary cycling at low resistance for 15 minutes, progressing to 30 minutes by week 4. She is educated regarding activity modification strategies, including use of a shopping cart during errands and taking seated rest breaks during longer outings. At 8-week reassessment, Margaret's Oswestry Disability Index has improved to 22%, representing a 16-point improvement that exceeds the minimal clinically important difference. Her leg pain has decreased to 3 out of 10, and her comfortable walking distance has increased to approximately 600 meters. She has rejoined her walking group, modifying her participation by walking with a friend who accommodates her pace and rest breaks. She transitions to an independent maintenance program with monthly follow-up calls to monitor continued progress and address emerging questions. Our second case study presents lumbar spinal stenosis with multiple comorbidities. Robert is a 74-year-old retired accountant with a complex medical history, including type 2 diabetes mellitus, hypertension, hyperlipidemia, obesity with body mass index of 34, and moderate bilateral knee osteoarthritis. He presents with an 8-month history of bilateral leg heaviness and cramping that develops with walking and prolonged standing. He reports that his symptoms are somewhat relieved by sitting, but not as completely or quickly as he would expect, and he has noticed some persistent numbness in his feet that does not change with position. His primary care physician is uncertain whether his symptoms represent lumbar spinal stenosis, diabetic peripheral neuropathy, or vascular claudication, and has referred him for evaluation and treatment recommendations. Examination reveals an obese man with antalgic gait pattern and bilateral genu varum. Lumbar examination demonstrates limited extension with reproduction of posterior thigh symptoms and negative straight leg raise bilaterally. The 30-second extension test reproduces his typical leg cramping. Neurological examination reveals diminished vibration sense at the great toes bilaterally and absent Achilles reflexes, findings consistent with diabetic peripheral neuropathy. Sensation to light touch demonstrates mild stocking distribution hyposthesia to mid-calf. Motor strength is 5/5 throughout except for 4+/5 bilateral ankle dorsiflexion. Hip examination reveals painful limitation of internal rotation bilaterally with groin discomfort, and knee examination demonstrates crepitus and mild effusions consistent with his known osteoarthritis. Vascular assessment reveals palpable but diminished dorsalis pedis pulses bilaterally, and ankle brachial index testing shows values of 0.85 on the right and 0.82 on the left, indicating mild peripheral arterial disease. MRI demonstrates moderate to severe central canal stenosis at L3, L4, and L4, L5. The clinical picture suggests contributions from multiple conditions: lumbar spinal stenosis producing postural-dependent neurogenic claudication, diabetic peripheral neuropathy, producing fixed sensory symptoms, mild peripheral arterial disease, and hip and knee osteoarthritis limiting mobility. This complex presentation requires a modified treatment approach addressing multiple contributing factors. Robert's baseline Oswestry Disability Index is 52%, reflecting the cumulative impact of his multiple conditions. His treatment program emphasizes aquatic therapy given his obesity, knee osteoarthritis, and need for reduced joint loading. Twice-weekly aquatic sessions include pool walking in chest-deep water, lower extremity strengthening through water-resisted squats and leg lifts, and flexibility exercises. Land-based treatment focuses on seated and supine exercises that minimize knee stress while addressing spinal mobility and core stability. His program includes cardiovascular monitoring, given his hypertension and mild peripheral arterial disease, with blood pressure checks before and after exercise sessions. Patient education addresses realistic expectations given his multiple conditions, emphasizing that improvement in the postural component of his symptoms is achievable while acknowledging that his neuropathic symptoms may persist. He is counseled regarding the importance of glycemic control for both neuropathy management and general health, and his primary care physician is updated regarding his exercise participation to support coordinated care. After 12 weeks of treatment, Robert demonstrates Oswestry Disability Index improvement to 38% and reports meaningful improvement in his walking tolerance, though he continues to experience baseline numbness consistent with his neuropathy. He expresses satisfaction with his functional gains and continues with a community aquatic exercise program for maintenance. These case studies demonstrate how the evidence-based principles covered throughout this course are applied in clinical practice to achieve meaningful outcomes for patients presenting with both straightforward and complex presentations of lumbar spinal stenosis. This concludes our comprehensive continuing education course on lumbar spinal stenosis. We have covered the pathophysiology, epidemiology, and classification of this condition, clinical assessment and differential diagnosis including the use of validated prediction rules and outcome instruments, evidence-based rehabilitation protocols encompassing manual therapy, flexion-based exercises, trunk stabilization, aerobic conditioning, and patient education, advanced rehabilitation strategies for special populations including frail elderly patients and those with high comorbidity burden, and finally, outcomes, prognosis, and clinical decision-making frameworks that support shared decision-making between clinicians and patients. The key takeaways from this course include recognition that lumbar spinal stenosis is a clinical syndrome requiring correlation between structural findings and characteristic symptoms, that comprehensive supervised rehabilitation represents appropriate initial management for most patients and produces meaningful improvements in pain, function, and quality of life, that long-term outcomes of surgical and conservative management converge over extended follow-up periods, and that treatment selection should be individualized based on patient characteristics, preferences, and values through a shared decision-making process. As rehabilitation professionals, we play a critical role in optimizing outcomes for the growing population of individuals affected by lumbar spinal stenosis. The evidence-based principles and protocols presented in this course provide the foundation for delivering high-quality, patient-centered care that reduces symptoms, improves function, and enhances quality of life for our patients. Thank you for your participation in this continuing education course on lumbar spinal stenosis. We will now review the exam questions to solidify your understanding of the key concepts from this continuing education course on lumbar spinal stenosis. Question 1. A patient presents with unilateral radicular symptoms in an L5 distribution. MRI reveals narrowing at the L4-L5 level. Which type of stenosis is most likely causing compression of the L5 nerve root as it traverses the spinal canal before exiting? The correct answer is C, lateral recess stenosis at L4-L5. Rationale. Understanding the anatomy of nerve root pathways is essential here. The L5 nerve root exits the spinal canal through the L5-S1 foramen, but before it exits, it must first traverse downward through the lateral recess at the L4-L5 level. This is why lateral recess stenosis at L4-L5 affects the traversing L5 nerve root. This differs from foraminal stenosis, which compresses the exiting nerve root at that same level, which would be the L4 nerve root at L4-L5. Central canal stenosis typically produces bilateral symptoms rather than the unilateral radicular pattern described, making lateral recess stenosis the most anatomically consistent answer. Question 2. A 70-year-old patient presents with bilateral leg pain during walking. Which clinical finding would most strongly suggest neurogenic claudication rather than vascular claudication? The correct answer is A, symptom relief requiring sitting or forward flexion rather than simply standing still. Rationale. The key distinguishing feature between neurogenic and vascular claudication lies in the postural dependency of symptom relief. Patients with neurogenic claudication must change their spinal position to experience relief because their symptoms result from mechanical compression of neural structures that worsens with lumbar extension. Sitting or forward flexion opens the spinal canal and reduces this compression. In contrast, patients with vascular claudication experience relief simply by stopping walking regardless of their posture because their symptoms stem from inadequate blood flow to exercising muscles. Once the metabolic demand decreases, blood supply becomes adequate and symptoms resolve within 1 to 2 minutes without any need to sit or flex forward. Question 3. According to the N-class clinical prediction criteria, which combination of findings demonstrates high specificity for the diagnosis of lumbar spinal stenosis? The correct answer is D, age greater than 60 years, negative straight leg raise, bilateral symptoms, and relief with sitting. Rationale. The N-class criteria, which stands for nerve root compression, lumbar assessment of stenosis syndrome, represents a validated clinical prediction rule for diagnosing lumbar spinal stenosis. The 5 key features include age greater than 60 years, a positive 30-second lumbar extension test, a negative straight leg raise, bilateral leg symptoms, and symptom relief with sitting or lumbar flexion. The negative straight leg raise helps differentiate stenosis from disc herniation, which typically produces a positive straight leg raise. When 4 or more of these clinical features are present, the specificity for lumbar spinal stenosis is high, allowing clinicians to make confident diagnostic decisions even before imaging is obtained. Question 4. Which aerobic exercise modality is considered ideal for most patients with lumbar spinal stenosis because it maintains a therapeutic spinal position throughout the activity? The correct answer is B, stationary cycling. Rationale? Stationary cycling places patients in a seated, forward-flexed position that naturally maintains lumbar flexion throughout the exercise session. This spinal position is therapeutic for stenosis patients because lumbar flexion increases the cross-sectional area of the spinal canal, reducing compression on neural structures. The clinical significance of this is profound. Many patients who cannot walk even 1 city block due to neurogenic claudication can often tolerate 30 minutes or more of cycling without symptom provocation. This demonstrates how powerfully spinal posture influences symptom generation in stenosis and why exercise prescription must account for positioning, not just intensity or duration. Question 5. What does the research evidence demonstrate regarding the long-term outcomes of surgical decompression compared to comprehensive conservative management for lumbar spinal stenosis? The correct answer is A. Outcomes converge and become statistically indistinguishable by 6 to 8 years following treatment. Rationale. Multiple high-quality trials have consistently demonstrated that while surgical decompression produces superior short-term outcomes compared to conservative management, this advantage progressively diminishes over time. By 6 to 8 years post-treatment, outcomes between surgical and conservative groups become statistically indistinguishable across multiple outcome measures, including pain, function, and quality of life. This convergence phenomenon has been observed across different studies and patient populations, suggesting it represents a robust finding rather than an artifact of any single study design. This evidence supports shared decision-making that includes realistic discussions about both short-term benefits and long-term outcome trajectories when counseling patients about treatment options. Question 6. According to the evidence presented in the course, which statement accurately describes the relationship between radiographic stenosis severity and response to exercise-based rehabilitation? The correct answer is C. Patients across all severity grades demonstrate similar responsiveness to rehabilitation. Rationale: research conducted by Shahidi and colleagues challenged the assumption that patients with more severe stenosis on imaging would respond poorly to conservative treatment. Their findings demonstrated that imaging-based stenosis severity does not predict rehabilitation outcomes. Patients classified as having mild, moderate, or severe stenosis all showed similar patterns of improvement when provided appropriate exercise-based intervention. This finding has important clinical implications. It supports offering comprehensive rehabilitation to all patients, regardless of their imaging findings, and challenges the practice of using severe structural narrowing as a criterion to exclude patients from conservative treatment trials. Question 7. When managing an elderly patient with lumbar spinal stenosis who also has significant knee osteoarthritis and obesity, which treatment modification is most strongly supported by the evidence? The correct answer is B, emphasizing aquatic therapy to reduce joint loading while enabling meaningful exercise. Rationale: aquatic therapy provides unique advantages for patients presenting with this combination of stenosis, obesity, and lower extremity osteoarthritis. The buoyancy provided by water immersion substantially reduces both axial loading on the spine and weight-bearing forces through arthritic joints, allowing patients to exercise meaningfully who might otherwise be limited by pain. Pool walking in chest-deep water reduces spinal loading by approximately 50% compared to walking on land. Additionally, the hydrostatic pressure and thermal properties of warm water provide therapeutic benefits that complement the mechanical unloading. This approach enables patients to participate in meaningful aerobic and mobility exercise rather than being relegated to passive modalities only or delaying rehabilitation indefinitely. This concludes our review of the exam questions. Remember that the key themes throughout this course include the importance of understanding stenosis anatomy and classification, recognizing the postural dependency of neurogenic claudication symptoms, applying validated clinical prediction rules, prescribing exercise that maintains therapeutic spinal positioning, and engaging in evidence-based shared decision-making that acknowledges the convergence of long-term outcomes between surgical and conservative approaches. Good luck on your examination.